ستارت ولا ويت ولا شيء؟
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Inshallah, we will have an excellent session this morning with a great speaker. So with this, we'll start. Our first speaker is Dr. Amal Al-Awami. Dr. Amal is a neurodevelopmental behavior pediatrician at Johns Hopkins Aramco Healthcare Center. She completed her medical school training at King Faisal University for Medicine and Medical Science in Eastern Province. She did her pediatric specialty training at Baylor College of Medicine, Houston, Texas, and Developmental Behavior Pediatric Fellowship at Tufts Medical Center, Massachusetts. Dr. Awami completed her leadership education in neurodevelopmental fellowship at UMass Kennedy Shriver Center in 2017. She also obtained Master in Public Administration through Suffolk University in 2018. She is a leader in neurodevelopmental disorder and passionate about improving the quality of care for kids with neurodevelopmental disorder. تفضلي دكتورة أمل.
Thank you, Dr. Saad, for this nice presentation, and thank you so much, everybody, for being here at 8:30 in the morning. I hope you're going to enjoy the presentations today. This is the second day. So I'll be talking about today is the update in assessment and management of complex ADHD. And allow me, I'm going to be speaking only in English. This is more of a scientific, really, presentation, and it is directed to the pediatrician and subspecialist. At the end, I may give some summary of what I said in Arabic for those who are interested to know it in the Arabic language. And I will start by thanking, really, the first conference in national development and their scientific committee, and on top of them, Dr. Ayat Al-Wahid, who really tolerated all my requests and complaints. So thank you for tolerating my whining, Dr. Ayat. I don't have anything really to disclose. Don't have any relationship with any pharmaceutical companies, and I'm not going to be talking about any medication that's not licensed. The outlines that I'll be talking about today is going to be overview and current diagnosis and treatment of ADHD, and then I will go over the complex ADHD definition and diagnosis, and comparison between the American Academy of Pediatrics and Society of Developmental Behavioral Pediatrics guidelines. And the bulk of my talk today is going to be about the management update in treatment of complex ADHD and what is the complex ADHD. And eventually we'll talk about the future recommendations. So the objective, I have three main objectives. The first one is to review the update and diagnosis of treatment in ADHD, and then recognize what is complex ADHD and when to refer as a pediatrician and what to do for treatment. And eventually we'll describe the treatment algorithms, and bear with me, there is a lot of algorithms that we're gonna go over. So we know that the most likely the prevalence of ADHD is anywhere between 5 and 16, and you could imagine the vast range of the prevalence between 5 and 16 because it's in different studies and different regions of Saudi Arabia and different methodologies. That's why we came up with that kind of either 5 or 16. But I think somewhere in the average of a 10%, that's what we have in Saudi Arabia as a prevalence. So the definition of ADHD, as all you know, it's really a neurodevelopmental disorder of childhood that is mainly having inattention, a pervasive inattention accompanied by or not with hyperactivity and impulsivity. And it really affects the function of the person and their development. So that's the pure definition of ADHD. But for complex ADHD, it is also the ADHD, but it's in either the lower age group, which is less than 4 years, or the presentation started after 12 years. And we will know now why these are a very peculiar age group. Or there is a coexisting condition, comorbidities of medical or psychological or learning or neurodevelopmental and mental conditions. Or it could be an ADHD with moderate to severe impairment. So we consider that as a complex ADHD. Or if they are not responding to treatment, or the physician is uncertain of the diagnosis. Why? Because there could be an overlap between it and the other conditions. So if there is uncertainty of the diagnosis, it's not a straightforward, that it's considered as a complex ADHD. So we set the standard that we know now what is ADHD, and we know what is the complex ADHD. You agree? Yeah? I see head nodding. Yeah, okay. All right, so ADHD is a neurodevelopmental disorder that is a lifelong, and I would like to put 2 lines under lifelong. So it's a chronic disease. Usually less than 10% will have no symptoms in the adulthood, but it's really a lifelong kind of disorder that impacts mental health and education, vocational outcome, and relationship. So you could see that the ADHD is not only a child who is hyperactive or inattentive, right? It affects your 360 degree of your life. It affects your social relationship, it affects your education, it affects your performance, it affects your mental health. So it is not a simple disorder. It is a disorder that really can affect the quality of your life. So just a reminder of the symptoms of ADHD. So the symptoms of inattentiveness, it could be that you have a careless mistakes, hard to maintain your attention. It's as if the person is not listening to you, doesn't follow through with the instructions. They have trouble organizing themselves or avoid mental effort tasks. So anything that needs a lot of mental effort and sustainability, they try to avoid it as much as they can. They lose things, you know, they lose their mobile, they lose their they loses their stuff. Easily distracted, often forgetful, okay? About the hyperactivity and impulsivity kind of symptoms, they could be fidget and squirm, so they cannot really sit still in their place. They leave their seat where they're supposed to be seated, runs and climbs, of course, in unacceptable places. They're unable to play quietly, so you hear them talking to themselves, having things falling down on the floor. They're talking, they're loud while they're playing, so they cannot play in a quiet way. They're on the go as if they are in dynamo, yeah? They're very talkative, they talk a lot, they don't stop, and they talk about certain things that they like most of the time. So they blurt answers, they don't wait for their turns. Trouble waiting their turns is very, very important. So they want to be the first, they're very interrupting and intruding into others. So you can see that these are some of the signs of hyperactivity and impulsivity. And I always put this slide in my talk because these are not part of the diagnosis of ADHD, but honestly, these symptoms affect the quality of life. And sometimes the presentation are one of these. They don't come to you saying, my kid is hyperactive. They come saying, oh, he's very chaotic and disorganized. This kid has very weak social skill. They don't have friends. And why is that? They don't read faces. They're very impulsive sometimes, so the other kids don't like to be around them. They have low self-esteem. Why is that? All of their life, all what they're hearing is negative things about themselves. You know that by the age of 7 years, these kids heard 20,000 negative words about themselves. So what is their self-concept? What is their understanding of themselves? Their understanding of self is negative, right? So they have low self-esteem. They have sometimes emotional dysregulation. Either they become very, very happy, very, very upset and mad, and so on. So they have the extreme sometimes of emotion. And sometimes that's what they present with. He blurred, he hit others, he bite others. This is like an impulsivity in their emotion. Unable to accept defeat, that has a name even, rejection dysphoria, that sometimes it's associated with ADHD. Low motivation, and honestly, the low motivation part, usually it is with adults. They say we don't have motivation to do things and complete our project. So that thing stays with them for a longer time. Unable to, or they like to be the center of attention. Sometimes they call it the joker of the classroom. People think it's a negative, but really they like to be in the spot of the attention. And eventually persistent insistence. They come to me saying, Doctora, they're breaking our head. If he wants something, he keep on and on and on. I want my iPad, I want my iPad, I want my iPad. And so on. The parents sometimes break down, right? It's like, take it, just go away. So the persistent and insistent is not part of the original diagnosis of ADHD, but honestly, it does affect the relationship around with the ADHDers and their family. Now, to have only ADHD, simple ADHD that has no other coexisting condition is only 30% of the time. So 70% of the time there are other conditions that's associated. So you could imagine that 70% of the time, possibly it's a complex ADHD. So anyhow, you could have tics, you could have the developmental coordination disorder, you could have autism, sensory processing disorder, oppositional defiant disorder, conduct disorder, phobia and anxieties, depression, behavioral disorder, and learning difficulties. So you could imagine the number of conditions that can happen, and sometimes not only one. You could have learning difficulty and anxiety and ADHD, and so on. So that can complicate really the presentation and complicate what is the differential diagnosis in that case. So I want to emphasize on that you have to focus on the functional impairment, either when you're taking history or when you're planning your management. This is very, very important. We're not looking only to control the symptoms of ADHD. We're looking for, in the management, to make sure that this person is functional. So this is very important, and I want you to take out from my presentation today is to emphasize on the functionality, and I will repeat that several times, so bear with me, let's go. So what is the functional impairment that I'm talking about, right? It's either in the academic, underachievement. Sometimes these kids, they could achieve up to here, but their performance is here. So what is this gap? This gap is in attention and impulsivity, because their ability is really there. So you could push them to do their own achievement abilities by just controlling the impulsivity and inattentiveness. So, and of course, having learning difficulties and disabilities that comes with it. What about the social interaction? They have difficulties with the parent relationship, parent with the child relationship can be really strained. And sometimes we start medication. If the mom said, I cannot take it, Doctora, anymore, I'm hitting my child. So once they start to have even physical restraints of that child, then I know it's beyond the acceptable. We have to do something about it. And of course, peers relationship. If they have also difficulties to maintain their friendship and to have a friend that they could play with, and some kids they avoid them, then you know that there is a problem in that functionality. How about self-concept? We talk about it, right? It is very important to understand that whenever a child is saying, I'm dumb, I'm lazy, I'm not worth it. So once they start doing that, then you know this is the time that you intervene. Not only that time, we should have intervened even before. But if that happens, then this is an impairment of their functionality, their understanding of themselves. And of course, what will happen if you have a low esteem? We're not talking about only a child who doesn't want to do things, right? This can develop in the future with anxiety and depression and so on. What about the functionality and activities? As you know, if you are very noisy, if you are very impulsive, then people will not invite you even for birthday parties, right? Don't you hear that? They're not invited because they can make a mess. So there is decrease in the activities and involvement, and of course there is increased injuries. They come to you with a scar here and a fracture there and so on. So that is the functional impairment that I'm talking about. So it's not only academic, and it's not only social. So there is more into it that we need to look into. This is one of the articles that I would like you please download and read, especially if you are a pediatrician or any medical field, that it is the American Academy of Pediatrics Guidelines for Diagnosis, Evaluation, and Treatment of ADHD. Okay? So how to reach diagnosis? Reach diagnosis by fulfilling the criteria. All 4 criteria that I'm going to be talking about has to be fulfilled to say that this kid has an ADHD. First of all, the symptoms has to be there before 12 years. Remember, complex ADHD is the presentation after 12 years of age, right? And of course, symptoms have to be present at least in 2 major settings, at home and school. The symptoms have to be impairing and interfering with the functionality, with social or education. Symptoms have to be there for at least 6 months. So if they come to you, they're having hyperactivity for 3 months, and you dig into the history and they lost a parent, or they change house, or they change school, or a new baby, then wait. Don't try to diagnose them unless it really persists more than 6 months, and this is very important. And it should not be explained by another mental disorder. So we agree that we have to have 4 of them, not 1, not 2, 4 of them. بمتحنكم ترى بعدين بسألكم مش الأربعة. حفظوهم. Okay? حافظينهم؟ تمام. All right. So how to do the assessment, right? So we have to take a detailed developmental behavioral history. This is very, very important because the diagnosis is clinical. We don't have lab work. We don't do EEG. We don't do MRI. There is no blood work. So it's a really developmental history taken. So you need to be a good historian, digging into things to know where are you. And what do we emphasize? Emphasize on functionality. Please, functionality is the most important. So we take the criteria of the DSM-5 have to be fulfilled. We have to prove that there is an impairment in more than one place. We rule other alternative causes of the symptoms. And of course, we screen for comorbid, either emotional, behavioral, or developmental condition, as we mentioned, because we want to know, do they have coexisting conditions or not? Other medical conditions like maybe seizures, tics, and obstructive sleep apnea has to be ruled out because they look like ADHD, or especially in attentiveness. And of course, we have to do some screeners. Remember, screeners help in the diagnosis. They're not diagnostic by themselves, like Connors and Vanderbilt. So what is the comparison between the guidelines between the American Academy of Pediatrics and Society of Developmental Behavioral Pediatrics? First of all, the population. The population in the AAP is mainly the kids who have ADHD. All right, but the society talks about kids and teens with complex ADHD. So their guidelines is directed to the complicated cases. Care provider in the AAP is the general pediatrician, family medicine, the first liners, right? But really the complex ADHD needs more specialized person, either developmental behavior or child psychiatry, child neurology, who really have more in-depth kind of training to know how to differentiate between ADHD and the comorbidities. And the assessment, obviously, you have to confirm ADHD in either way, but in the main, in the SDBP, is the really comprehensive assessment of ADHD and the coexisting conditions. So we don't really concentrate only on ADHD in that case. Management, usually psychosocial and medication in the AAB guidelines, but you look at the SDBP, it really emphasizes on psychosocial intervention as a foundation for all of them, and medication according to the impairment, and we will see in a minute what does that mean. Okay? All right, so let's go for the first algorithm. The first algorithm that we're gonna talk about is really the evaluation of children and teens with ADHD. And I'm going to emphasize, scatter it one by one, so we'll go over it one by one. So, as I said, you need to obtain a comprehensive history, review supplemental information like IQ or school record or whoever evaluated this child before, perform interview, and you have to really sit with the child. Anybody who's 6 and above, you have to sit with that child alone sometimes, play with them, know their thoughts, know their language, know what they're thinking about, and of course observe how they are interacting in the clinic. Then if ADHD is confirmed, then, of course, you assess for coexisting condition. Remember, this is a complex ADHD pathway. And if there is a condition like coexisting conditions, that's what or there is none, sorry. If there is no coexisting condition, then we go for another pathway that I'm going to come to it in just 1 minute, which is a behavioral education treatment. So you remember that we have to always start with a behavioral intervention, right? So if there is no coexisting condition, but the child has ADHD, then we go for the behavioral pathway. If there is a coexisting condition, obviously, then we go for another algorithms that I'm going to be discussing at the end of the lecture. 3 algorithms that I'm going to go about, which is the presence of autism with ADHD, the presence of anxiety with ADHD, and the presence of disruptive behavioral disorder. Otherwise, there are other algorithms that if you are interested to go over and read about. So in case that ADHD is not confirmed, then we consider other diagnoses, obviously. Maybe it could be anxiety from the beginning, or it could be some kind of social problem, and we have to really emphasize that there is no ADHD. So otherwise, if there is no, then we go for treatment of that condition that we reach a diagnosis with. Okay, so this is the first pathway, and it's really only for evaluation to know where are we, yeah? And then we go for the next step, which is how can we manage these children. So now we're gonna go, as I mentioned, to the behavioral and educational pathways or treatment complex, and we always start with psychoeducation. Now, the Society of Developmental Behavioral Pediatrics emphasize that you sit with the parents, explain to them what is ADHD is all about, and what is their option, and why the kid is doing whatever they're doing. They have to be on board. You cannot just say, this is ADHD, medication, or whatever, and go on. You have to have a time. It's even better if you have pamphlets or some guidelines or some information, because sometimes they don't really get whatever you're saying at that time. They may want to read it later, or give them resources. Resources are good, but psychoeducation can be a mainstay, really, because if they don't understand what's going on, they are not with you in the same boat. You are traveling in a different direction, okay? Talk about risk and benefit, reach a mutual treatment plan, begin evidence-based behavioral intervention, evidence-based. This is very important, and we're going to talk about it. And what do we focus on? What you're going to come out from my lecture? Functionality, right? Okay. And then emphasize on behavioral parent training, which we don't have in a way that we would like it to be. We do give the parents some tips how to parent their children, but there are other really well-organized kind of training programs that we'd like any one of you who are interested to go and search it and maybe start a treatment plan intervention. School-based intervention, remember, it's a pervasive, so we need a school to be with us also. We have to give them at least what we would like them to do in the 8 hours that they spend, or 6 to 8 hours that they spend at school. Peer-focused social skills. Remember, peer relationship, their interaction with their peers can be affected. And usually, where is that happening? It's happening in the school. So usually teachers, if there is any teacher here or a school psychologist, that we really have to emphasize on promoting these kind of relationship together. We cannot just say, oh, he doesn't know how to play with this. He's just all over the place. And maybe he pushes away the other children and nobody wants to play with him, and that's it. No, you have a rule. We have a role, actually, to really emphasize on how we could advance their relationship. And at the end, organization skill. Remember, ADHD, we're not going to talk about that, but ADHD does affect your executive functions. So one of them is the organization and planning, initiation, inhibition, and so on. But the organization skill is very, very important, especially to do your homework. Okay, so eventually what do? We do a brief assessment of functionality. As I mentioned, you have to prove that there is impairment and do an rating scale. What's next? Next will be, okay, so once you know that there is impairment and there is continued in the impairment of that functionality, then we're gonna discuss with the parents about their preference, what's their options, it's very important, yeah? What are the available resources? I cannot just say, oh, go to the parent training program and there is none, right? I cannot do that. But we have to have what we have in the resources around us, either online or in person, risk and benefits. Even if they choose not to treat, remember that, they need to know what is the risk of that, yeah? What is the benefit of treatment? What can be option? And don't close the door. Go think about it and come back to me, yeah? So it's very important to open that kind of door and dialogue with the parents. Now, if there is no continued impairment and whatever we're doing is great with that child through the peer intervention and academic intervention, then you remember you're always gonna see this code, maintenance monitoring. So we cannot just leave the child after treatment or after diagnosis or even no diagnosis or maybe no treatment, medical treatment. We have to continue following these children. So for those who have a complete service for developmental disorder, they have to plan ahead that how many times they will see this child, maybe twice a year, maybe 3 times a year. Annual check for coexisting. Maybe you cut him very early and now they're having learning difficulties. And of course, adolescents usually are very specific age. Remember that they could be a risk taker, they could be smoking, they could go into drugs and so on. So you have to always remember to talk about it, even at least smoking and not driving without a license, right? Because these things can happen. So if the maintenance are good and everything is fine and the functionality is stable, we continue in that cycle, which is a maintenance kind of monitoring. But if the symptoms are changing with time, then we go ahead and look for coexisting disorders. And if they are present, then we go for that algorithm. So you could see that things are connected, right? So we start with the evaluation, we start with the treatment we want, and if that treatment doesn't work, we'll go for something else. So, and as I mentioned, we're gonna talk about some of these algorithms later on. And if these coexisting disorders are not present, then you have 2 options, really. Either you intensify the behavior treatment because we have somebody who has ADHD but not doing well, right? But there is no coexisting problem. So intensify your behavior treatment, additional parent training, individualized focus. What is the problem really? Is it only because he bites others? Is it because in the morning you have a problem to go to school? What is the problem? So we have to focus on that problem and give a plan for it. Intensify peer program and special education services as needed, or we go what we call a complex ADHD medication now. Yeah, did I mention medication before now? I haven't. So now we go for the medication if we need to. Okay, now just remember this slide that we stopped at the parental preference, and really you have 2 options. Either we go to the complex medication or we intensify again the treatment for us, because these are our options that we're going to talk to the parents about. And in either way, honestly, we have to continue checking for the impairment, and if there is anything that we go to medication. So medication is really the last resort, because people will say, okay, Doctora, so you diagnosed it with ADHD, are you going to give us medication? That's not the first line. Let's talk about something else. Let's talk about really the multimodal intervention that I'm going to be talking about in a few slides. So remember, the management and intervention has to be holistic. You cannot even treat ADHD alone. You have to treat sometimes the family. Sometimes if you have parent conflicts that affects the child, you have to at least give advices. And if they need couples counseling, or if they need to be present together and you talk to them, you have to spend some time, because sometimes you spend a lot of time giving the right management. But if you don't make sure that it's going to be implemented, then honestly, this is a waste of your time and their time. So always look holistically at the child. So we talked about the multimodal, right? What does multimodal means, really? First of all, I always say that. So, Doctora, we don't want medication. Fine, sure. So what can we do? We go for general consideration. That's how I call it. First of all, sleep well, eat well, have routine, eat at the same time, sleep at the same time, have some regulations in the school, at home, what is accepted, what is not accepted. Exercise, screen time, right? Everybody has to think about screen time. How can we control screen time in kids with ADHD? And of course, exercise. Did I mention exercise? I'm going to mention it again if I don't. Exercise is very important. There's beautiful studies about exercise and the effect on dopamine and how it helps the attention and hyperactivity. And then we go for the behavioral intervention, which means if there are some behaviors that needs to be modified, or there is behavior that's not there and you want to see it, right? You want to plant that kind of behavior. And eventually the academic, they are a major role. Teachers, school system is a major role in the management of ADHD. Because if they don't do their role in the other side, really having only medication on board, that's what we can as physician to do, may not help. Eventually psychological, having an ADHD coach. Have you heard of an ADHD? Who heard about ADHD coach? Yeah? Wallahi, very little, less than 10%. ADHD coaching is very, very important. They don't really teach you skills, but they help you to, I will say, know the skill how to do it. Like if you have a big project, right, and you need to submit it by the end of December. Sometimes you think, oh, you know what, I'm not gonna do it now, I'm gonna do it next week, the week after, so there is like procrastination, right, tasweef to the end. So they help you to bring that big project into chunks, what to do now, what the deadline is in a week time, and so on. And they really help also emotional regulation with that sense. So psychological part is very, very important through CBT or through dialectical, even behavioral therapy, and so on. And at the end, medication, right? And I think everybody think about medication first, but please remember medication is not the last resort, but it is one of the options, but we have to think about management as a multimodal intervention. Do we all agree? Yeah? Okay, very good. So ADHD is a chronic condition. It's not a pneumonia, you give 10 days of antibiotic. It's not ear infection. It is like diabetes. I always say, this is the best example. ADHD is like diabetes. First of all, if I tell you, do you need, let's say, to modify your life and give medication, will you say no for diabetes? Most of the people will say no. But for the ADHD, they think about it. So always give that example to the parents. It is a chronic disease. We have to deal with it as medical people also as a chronic disease. So we have to think, it's not only one time given medication, it is really the follow-up that we talked about. And you put together, work with the family to have a SMART goal. Why is that so? Haven't you heard of people, we started medication and it did not work? We all heard that, right? Why? Because it wasn't clear what was their goal. Maybe their goal is different than your goal, different than the teacher goal. So we have to put a specific, measurable, attainable, and realistic with the time bound kind of a goal. If you train the parents to think about it that way, then you are helping these parents to be more objective. So they will know really if the medication did their job or not. If your goal is that the child do their homework alone, then this is a goal. Beautiful. How many in 1 month, 2 months? How many times? 15 minutes, 30 minutes? You see how you are specifying now really the goal of the treatment of the parents. So a SMART goal, work with them. They don't know how to do that. You need to work with them to do it. Include teachers. I have to emphasize on it again and again, and always monitor progress. So the goal of treatment is to do a self-management. You manage your attention, you manage your emotion, you manage your impulsivity. That's really the goal of the treatment. And skill building. If you have difficulties in certain things, maybe social interaction, then we build that kind of skill that you need. So we have to do, where is the deficit? Look for the deficit, look for functionality. Right? So we go for the skill and we help that person to build their own skill. And we, of course, I mean, do no harm as physicians, right? We have to prevent the outcome either from the medication itself or from leaving this child without intervention. This is the second article that it is another important one. Usually it is more for specialized people that talks about complex ADHD, and it is published, the guidelines published by the Society of Developmental Behavioral Pediatrics. And honestly, I'm gonna go over now their algorithms. So bear with me. If you are tired, please stand up, because we're gonna talk about a lot of algorithms. Stand up, all of you, come on, stand up. Thank you. اللي قاعد يقوم معلش. You will have more dopamine now in your body. Yes, sit down. Thank you so much. Because it's very important. Now the algorithms are very interesting, but it needs your attention. And by now, just moving, I think you have better attention, right? Because that's what ADHD needs, really. Sometimes you have to really do something different physically to be more attentive. All right, so just to a reminder for those who maybe did not hear about what complex ADHD is, it is really dependent on the age, either less than 4 years or more, representation more than 12 years, co-occurring condition, moderate to severe impairment, diagnostic uncertainty, and inadequate response to treatment. So this is a complex ADHD. I'm going to give you just the highlight of that guidelines now. First of all, it is shared decision making. I emphasized on it that we need parents to be on your boat, the same boat. So it's a shared decision making. We have interprofessional care, as you could imagine. It is not the physician. We need a psychologist. We need school psychologists. We need teachers. We need parents. We need everybody. So it really, there is an interaction between all the personnel that takes care of that child. كأنك أنت واقف في صف يعني لو عدي كده شوية بس. Comprehensive assessment, doing psychological testing and mental health assessment as needed, and of course multimodal treatment that we discussed, and of course a life course perspective. So these are the mainstay of the guidelines, and we're going to go over the guidelines now. Again, I'm just reiterating that management has to be interprofessional care, developmentally appropriate, because we cannot ask a 3-year-old to do exactly what a 10-year-old do, right? It has to be evidence-based and culturally sensitive. We need to be careful. We cannot bring somebody who doesn't know our culture and give the recommendation to our parents. We need to know the culture, not only the usual culture, the culture of that family. Because they are different. Trust me, we're all in Saudi Arabia. It doesn't mean we have the same culture whatsoever. So spend time to understand what the parents think of, what is their priority, what is the culture in their house. Because that way you could always meet them where they are and build on what they have from knowledge and so on. Okay? So in the case of co-occurring, this is very, very important. In case of co-occurring psych disorder, we treat the symptoms that's the most impairing. Yeah? What does that mean? If you have ADHD and an anxiety is the most impairing, that we need to start treatment and anxiety. We cannot treat ADHD. Or ADHD and obsessive compulsive, and that is preventing this child from being in the school, then we need to treat the OCD. We cannot treat the ADHD first. So we need to first treat the symptoms that's the most impact in what? Functionality. صح؟ تخيلي ما بتنسى الفانكشن اليوم. No way. طيب, in treatment, focus on reducing impairment than reducing symptoms. What is the use of a child who is, not distracted, not hyperactive, but not doing well at school? What is the use of a child who is not hyperactive, but he doesn't have friends? So not only the symptoms that we talk about, really, we would like to have functionality the most important. So even if you reduce some of the symptoms, that doesn't mean you reach your goal. Your goal can be different, okay? So function, function, function. So we're gonna go now on the complex general medication treatment, more than 6 years, and I'm gonna talk about the 3 to 6 in a few minutes. So if you have a child and teen with inadequate response to the behavioral education, and you remember that algorithm that we talked about, the behavioral educational part, and emphasizing on the peer relationship and parenting training, you remember that algorithm, right? If that fails, then we go for the next. First of all, what do? Psychoeducation. Go again, educate the parents, make sure they understand their risk and benefits, and do baseline ADHD that we can depend on. And please take some of the side effects that can happen for the medication. Physicians around who give medication, didn't they face sometimes, oh, doctora, once we start Concerta, he's not sleeping well. But honestly, when I go back to my history, he was not sleeping well even before Concerta. But now after the medication, because they know it can affect sleep, they're thinking that the Concerta affected sleep. So you have to get the most likely side effect before starting the treatment, which is really you go over the headache, appetite, sleep, GI, and tics, because sometimes even the tics will happen later and people think it's because of the methylphenidate, but it's there, but nobody had noticed them. So think about taking all of that and establish a goal and target with the parents before you start treatment. What is your goal in the treatment? It's not only that he stops jumping on the couch. Let's talk about the functionality. What do you really want? And of course, later on, we start the usual, either methylphenidate, or amphetamine, if available. And amphetamine is not available all over Saudi Arabia. Of course, there is a role in the medication. You start low and you go slow. Yeah? So you really have to start with the lowest dose and you increase on it. Okay. So now, I want you to think about this table. After you start treatment, you have 4 options. Either you have adequate response with minimal side effect, and I'm gonna put star on it. This is what we want. I want a real response, but low side effect. But you could always have inadequate response and minimal side effect. And what about adequate response, but significant side effect? What are you gonna do? And of course, the last one, having inadequate response, significant side effect, is so obvious. But I'm going to go over it with you one by one, because this is very important. So we always think about benefit versus risk. What is the benefit and risk? If the benefit is way good, يعني 10 kilo, and the risk are 5 kilo, then it's okay. But if the risk is really higher than the benefit, then think about it. All right, so let's go over one by one. If you have inadequate progress but minimal side effect, what are you going to do? What's next in the algorithm? What we do is we increase to the next dose, obviously, because you don't have a lot of side effect. Reassess in 1 to 2 weeks, and you have to bring this person in like 4 weeks, and always remember the guidelines or the algorithm القديمة, we have to go back to the behavioral and education, make sure that it is done right, okay? And then re-evaluate. If these symptoms, functionality, target are stable with minimal side effect, then what we do is maintenance. Remember, always maintenance. Whenever you reach whatever you need, we don't leave the child. I've seen a lot of kids who are given medication and never given a follow-up. You cannot do that. So after medication, we have to really have a follow-up that is needed. If still there is a problem, always think, are there or coexisting disorder that you're missing? And then we go for that kind of algorithm. So first of all, you start medication, you have not adequate response, no side effect, you increase the dose, maybe they're doing well. If they're not doing well with the increased dose, then you go for any coexisting abnormality or conditions. How about treatment achieved minimal side effect? You're happy, the family is happy, right? So what do we do? What do you think we should do? Nothing, right? But we do maintenance, continue, of course, the medication, and we may go to the maintenance monitoring, as we mentioned. How about the third one, which is symptoms function improves? We're happy, but there is significant side effect. These kids can come to you with a loss of weight, 3-4 kilos in young children. That's a lot. We cannot really accept that kind of side effect, right? And so what the question is, can these side effects be tolerated? Can we do something about them instead of changing the medication? If we can do that, then fair and good. We go to the maintenance. because it's tolerated. If the side effects are not tolerated, then we have to change to other medication, okay? We have to change to other medications. Sometimes we decrease the dose, but anyhow, we will get less effect, and always intensify the behavioral intervention. The last one, which is inadequate progress and significant side effect, obviously, you change the medication and possibly you intensify your behavior. So it's the same thing because they meet up at that corner. All right, so that is what? That was the medication on the age of more than 6 years, okay? Now we're gonna be talking about the younger age, which is the more complex one, which is when they start preschool from 3 to 6 years of age. First of all, the first line of treatment is really parent behavioral intervention. You have to give these parents some tools. They feel very hopeless because they cannot really tolerate this child and they may hurt this child. So help them with at least some of the authoritative kind of parenting style that will help them to put rules and regulation but be compassionate and empathetic. So it is very important that we need to do parent training. So we have a preschooler with inadequate response. Again, we do psychoeducation, obtain baseline rating scale, and of course functionality again, obtain side effects again, because their side effect is more than others, and consider intensifying again. See, we go back to, we have to intensify the behavioral education and treatment. So does this child now, the question, if they are not improving very well, so do they have impulsivity, aggression, irritability, oppositional? We heard that a lot, right? He doesn't listen, he opens the door and run away, he's very aggressive to his younger child, right? So if these are present, okay, then what do? We go ahead for medication. And the medication that is advised by the Society of Developmental Behavioral for treating a 3 to 6 years age with aggression and irritability is alpha agonist, is clonidine, okay? But if these are not present, then we go ahead and give them methylphenidate. We start with the lower dose, which is 2.5. In either case, we have to assess. We cannot just leave. This assessment has to be on a weekly basis at the start, because these kids are small, you don't know what kind of side effects they will have. Okay, so again, it's gonna be the same thing. We have 4 kind of reaction after treatment. It's either inadequate progress with minimal side effect, titrate up, and in this case, we're gonna do BID or TID, which is 2 to 3 times a day. If you reached your target, most of the time, people think about increasing the short-acting methylphenidate to intermediate or long-acting. We don't have the intermediate in Saudi Arabia. We hope that we will get it. But the long-acting is a capsule, again, if they can swallow a capsule. So there is some limitation sometimes that we face as physicians on what to choose and how to treat. But anyhow, that's the recommendation. And if everything is okay, then maintain your monitoring. If symptoms are not good, again, it's the same idea. Can they be tolerated? If they can, the side effects can be tolerated, we go to the maintenance. If not, then we have to, same thing, change to a different medication. So at least you have an idea now, if you're facing a difficulty, what to do. Because we cannot just, I don't know, what am I going to do now? What am I missing? Are they compliant? Is that a good dose or what? So we now know if you have, I will say, inadequate responses to your medication, what you need to do next. So I think this makes us in ease in the management because we're doing an evidence-based intervention. Okay, remember that the indication for medication in preschooler is the following. Moderate to severe symptoms with functional impairment. I have a child who puts the mobile of his mother in the microwave and turn it on. It was about to explode. I mean, that was like beyond. She has 3 locks on the door for their apartment. Because the minute she forgets to block them all, he will immediately go. I've seen a video of him, oh my God. He's like all over the fridge. He's sitting on the fridge with his mobile because he doesn't want to be anybody to see him. So sometimes the safety risk is very, very important that you consider because really they are very impulsive, they don't think, and they come with a lot of injuries. Like, of course, I'm sure all of you thought, we don't have behavioral intervention in our place. What do we do? So the society tells you if there is no evidence-based behavioral intervention and you are left only with medication. So you start medication. Of course, evidence of impairing comorbid like ODD and disruptive behavioral disorder is another indication to start medication. See the pink one. Pink, red, orange, it depends how you see it. But see that one. It says that the response in children 3 to 6 years is less than others. Okay, now you're going to medication, but the response is not the same. And the side effect is more. Okay? So think about them. You're given medication. Parents has to know, I'm gonna go to the medication because 1, 2, 3. And remember, the medication may have more side effect and less response, but we're gonna give it a try. Me and you, we will give it a try and see how does it work. Trust me, if you go that way, people say, yes, can we stop it if we want to? Yes, we can stop it if we want to. So they feel secure that these are trial, and it's a scientific, objective trial that we have a goal for and see if that's effective or not, okay? So we're gonna go over now the coexisting condition that can happen with ADHD. I still have time, صح شباب? I still have time? Very good. All right, so if you have a child with ADHD and ASD, right? Remember, people are still shying away from diagnosing ADHD with ASD, but really it does co-occur in 70% of times. We have to really know what is the differential between them, what is really related to the ASD and what is related in ADHD. Sometimes they're blur. The line between them is very blurred. You don't really differentiate between them well. And sometimes you have to treat because the functionality is the most important. I want this kid, when they get the intervention of ABA and speech and all of that, to get benefit out of it. Because if they are all over the place, sometimes they are not able to give that kind of intervention a chance. I always start with intervention. They come back to me. If I think the ADHD is beyond the accepted, then I go ahead and start treatment. So anyhow, so what the society tells us is they have to have this person with both dual diagnoses, the most evidence-based behavioral education treatment for ASD in particular, like applied behavioral analysis, therapy for communication, any kind, maybe the AAC, which is alternative augmentative communication, home-based behavioral support, and special ed services. So if they receive all of this, now, I always have to ask myself, is the impairment related to ADHD or is the impairment related to the ASD? Remember when I told you if there is two coexisting, what do we think of? Which one is more impairing? Is it the coexisting or the ADHD? So that's the question that needs to come to my mind. If no, then what do? Monitor, only monitoring, because they're getting enough intervention and the impairment is not really because of the ADHD. Of course, if the ADHD is the mainstay and the main impairment, then I ask myself, is it only the primary symptoms? If yes, then we go for the complex general medication algorithm that we just talked about, yeah? So it's really, everything is connected to each other. So you have to all know all the algorithms to be able to give the right intervention. Of course, always functionality is in our mind. If we find the function is stable, then we go ahead for monitoring. But if the functionality status is unstable, yeah, then we do think about other additional. Now, remember when I put all of these bubbles, that sometimes ADHD comes with multiple coexistence, so sometimes there is an ASD and an anxiety, right? There is ASD and developmental coordination disorder, and so on. So think about even when there is a combined, if there is a third combination. And in that case, then we go for the algorithm that is suitable for the additional coexistence. Now, coming to the impairing symptoms in the core of ADHD now. Person with ADHD and autism, but the main symptoms is ADHD. What do we do? Okay, the impairing is the one. Have you ever heard me talking about atypical neuroleptics till now? This is the only time, please, this is the only time that risperidone and aripiprazole is needed. It is not because this kid has ADHD that people start them on these neuroleptic medication. These are antipsychotics. It has to have its own indication. And the only indication for it is really the impairment, having aggression, disruptive behavior, and irritability on top of the autism, on top of the ADHD. So we're talking about layer after layer. Then I go for something as risperidone. Do we agree? Please come out from this lecture by this information too, because we see in the community, and you are highly professional here, we see in the community that there is a lot of use of these neuroleptics that's not really needed. Okay. Of course, if there is none, then we go for the same thing. How about anxiety? Ready for the anxiety? I'm sure psychiatrists here will be happy now. Yeah? Okay, very good. Psychiatrists and psychologists, لا حد يزعل, huh? All right, so if you have a child with both ADHD and anxiety, is anxiety more impairing than ADHD? If yes, then we start CBT. This is the first mainstay in children, which start with cognitive behavioral therapy. This is very, very, very important part. And monitor response. And if that fine and improves and it is less impairing than ADHD, then we continue on the treatment for anxiety. We even, if it is not improving, that's, I'm sorry, I forgot to say that. If anxiety improve, it doesn't improve, this is no. So you continue CBT and modify some of the parent. If it is fine, then we go for the behavioral educational treatment. But if we continue CBT, okay, and anxiety, and I ask myself, is anxiety improved and now less impairing? If yes, then we go for behavioral intervention. Now we'll go to no, then we have to start now medication. So the medication did not start from the beginning for the anxiety, right? Anxiety there, we do CBT. If no improvement, continue CBT and do modification for the parents. If that did not help, then we start with SSRI and continue on the CBT. If we initiate an 8 weeks of SSRI and we continue CBT and we look into is anxiety improving, then if it is, then fair and good. And if it's not, which is this one, then we continue on the CBT and consider medication change, which means if, okay. You know, I hope that I didn't lose you here, because this is an algorithm. Sometimes you have to really look into it one by one. So we treat the anxiety because the anxiety is the most impairing, okay? If that continues the case, then we continue treating the anxiety part. If after treatment, the anxiety, now the impairing is ADHD, then we go for the ADHD pathway. Did you get that? Yeah? So if the anxiety is the main course, we go for the route of anxiety. If at any time the ADHD comes first, then we go for the route for the ADHD, okay? This is more specialized, as I said. This is more for child psychiatry, child neurology, and developmental behavioral, because you have to really dig. Did you see how much digging there is in the impairment on which is affecting the function of the child? Okay. So what about the disruptive behavioral disorder? I added this because they told me I have enough time for it. So now you look at the disruptive behavioral disorder, and it has its own diagnostic criteria that we're not gonna go over now. So always think, is the impairment from it severe enough? If it is no, then we treat the ADHD. Always the same idea. It depends what is the more impairing part. If the impairment is more of the DBD, then we go evaluate the services, more behavioral intervention, even the implication of evidence, more intense evidence-based behavioral treatment. Because remember, medication does not really help in these cases a lot. We need to do a lot of behavioral intervention in these cases. And now we ask ourselves, is impairment from DBD is still severe? If yes, then we go for more high intensified medication and consider pharmacological at this age, yeah, at this time. So if you really don't have another resources, if the impairment is not so severe, then we continue on the ADHD treatment. So again, in all of these coexisting conditions, the main rule is which is the more impairing. We go for it, we treat it. If the other one comes up, then we go for it and we treat it. And you have to always think in that there is like steps of treatment for each one. For the anxiety, we said CBT, and then we go for SSRI. For the disruptive behavioral disorder, we go mainly behavioral, intensify behavior than medication. So you could see that there are steps and layers of intervention. Okay, so what is the long-term management? We prepare for key developmental transitions, and we really talked about some of the transitions yesterday. It's the medical transition. Having kids graduating from my clinic because they reach the age, where do they go to? This is difficult for the parents. They want to, but I cannot really treat adults. I don't know how to treat adults. I know only how to treat children up to 18 and sometimes 21 years of age. But somebody else has to take over. So that kind of transition. And also personal transition. Transitioning from preschool to school, from elementary to middle school, and so on to college. So preparing for this transition is very important. Standardized questionnaire has to be done at least 2 to 4 times a year, and we always screen for emerging coexisting condition, because sometimes an anxiety doesn't happen at the start. A depression has to maybe starting at the teenage. So always put in your mind, is there is something else I have to do while continuing monitoring them. So what I want from the medication management is really to monitor the therapeutic side effect and medication at least in the first 30 days and then stabilize it. Management or medication management visit has to be every 3 to 4 months, and review the weight and height and blood pressure and pulse rate in each visit, because that's the effect of the medication. So take-home messages, which is my last. You don't have to really tick the clock on me now, because I'm finishing. All right, so comprehensive assessment, exploring symptoms of ADHD and the coexisting condition is very important. Second is focus on functional impairment. كان المفروض أحطه في البداية بس معلش جاء في الرقم 2. Psychoeducation is fundamental. Please buy the parents on your side. And interpersonal or professional care is needed. Multimodal treatment we talked about. And in the case of co-occurring psych disorder, treat symptoms that most impact functioning. Okay? So these are some of the resources, but I will leave you with this slide because I highly recommend that you all, if you are interested in ADHD or have ADHD, you in particular, to جمعية إشراق على اليمين. And there is the Attitude Mag, which is beautiful magazine on a weekly basis. They have a podcast and information, and the chat usually for the adult ADHDs. They have beautiful resources. So thank you so much.
Thank you, Dr. Amal, for an excellent review of the management of not only complex ADHD and complex ADHD. I will open the floor for question.
I remember one professor said, if nobody has a question, they either understand everything or he didn't understand anything. So please let me feel that this first one, you understand everything. تحتاجوا مني أقول شوية بالعربي ولا you get it. إذا أي حد يحتاج على كل بالعربي ولو في سؤال ممكن بعد المحاضرة تحبوا يعني نتكلم عن ما يسمى بالفرط الحركة وتشتت الانتباه المعقد شوية. أوكي؟ إذا أي حد مو فاهم نقطة معينة بليز قول لي وأنا مستعدة أشرحها.
تفضل.
شكرا لحضرتك. يعني rule of genetic factor in ADHD or autism, another psychological disorder.
ما فهمت السؤال. I'm sorry.
Rule of genetic factor.
Genetic factors.
In autism, ADHD, another psychological disorders.
So if I understand you right, you're telling me about the origin, the etiology of ADHD and autism, if there is any genetic role in it. Is that the question? Very good. All right, so we know that at least in the autism, it is 80% hereditary. and there was beautiful genetic lectures yesterday, but it is most likely hereditary. And why do we say that? Because of the family studies. So if there is a twin, identical twin, there's higher chance of having both of them to have developmental disorder than having non-identical twin, than having a brother or a sister. So in that case, if let's say autism is 1% to 2% in the community, if in the brother, the sibling, maybe 20%. In the non-identical, 40%. In the identical, 60%. What does that mean? There is more hereditary I will say influence, but it's not a genetic. So it's not one gene that is affected, it's a multi-gene hit, that's what we call it, eventually that present with autism. For the ADHD, there is a good studies about certain transmitters defect genes that can cause, in particular, some kind of ADHD in certain people. But that's not the mainstay. And you could imagine that I'm talking about real management. The management, I would like you to ask me about the management part. Did that answer your question?
So actually, I will add something. We have a multiple family where we have ADHD and autism in the same family.
True.
And there is many study went into looking at the genetic of ADHD. And as Dr. Amal said, there is multiple gene involved. Actually, the head of genetic in National Institute of Health had Dr. Maxwell had done many work in this regard. And I believe we should really, in this country, we should do more, because the consanguinity play a major role in hereditary disease. And I think we will, if we work on this, we'll identify the gene responsible for ADHD and coexisting autism in this part of the world.
And thank you, Dr. Saad. And I always think, having a family history taken to understand is there is anybody else who has autism, ADHD, bipolar, schizophrenia, and anxiety does help you, because it's what we call a genetic load. There is a genetic load that can formulate your diagnosis on this person. It increases the chance of having developmental disorder, but it doesn't prove it. Any other question? There is a question in the back.
Assalamu alaikum, Dr. Sana Ishaq, pediatric neurologist. Thank you, Dr. Amal, for your very informative lecture. I was very happy to listen about this complex ADHD, because we have a lot of families with the same problem. Kids are very annoying them, and sometimes they are impulsive and holding knives to kill somebody else in the family, like that. So you mentioned that we have family program. Is it really available in our society? Because we tell the family, you should have a program for behavioral family program, but we don't know where to guide them. Is there a way to guide them, or a center to send them there?
And honestly, from this podium, I would like to ask all the organizations that are present today or hearing our talk today that we have to have a plan, something like that, either virtual or in person, to help families to do parenting behavioral modification. Honestly, the only one that I know of for the time being that is mainly directed to autism, not ADHD, is مركز التميز للتوحد. They are training hundreds of families every now and then by, I think, 12 sessions, one per week. So this is good to understand autism and to understand how to deal with them. But for ADHD, correct me if I'm wrong, anybody, there is none that I know of that you can depend on. But it is something you in your center, anybody in their center, start something like that, because there is a big gap there.
I actually will confirm with Dr. Amal. Right now, there is a huge gap in the management of ADHD. What is available to the family, and of course to these kids, is very limited. And maybe this is إنه إن شاء الله الجهود المباركة اللي بدأت بهذا المؤتمر، إنه we all pledge that we have to try, each one of us will try his best to bridge this gap in the future. You know, we should not stay status quo. We should do something about it, each one of us.
Absolutely. في هناك
السلام عليكم ورحمة الله. معليش عاملة عملية، ما عارفة صوتي سامعينه ولا لا، بس ركزوا معاي في الصوت شوية. معكم دكتورة سوسن علي يوسف من السودان. نشكر الناس الغائمين على هذا العمل الجميل، وكنا نتمنى أن نكون مشاركين بورقة، لكن سمعنا بالمؤتمر وخري. سؤالي يا دكتورة، بعض الأبحاث بتشير إنه الطب البديل يمكن أن يقلل من أعراض فرط الحركة والانتباه، فكيف الكلام ده؟
شكرا جزيلا دكتورة سوسن، ومع أن صوتك يعني مبين أنه متأذي، بس شكرا للسؤال وشكرا لتواجدك عزيزتي. طبعا السؤال كان يقول what about the alternative medication or الطب البديل. طبعا الطب البديل كلمة فضفاضة كثير صراحة، لأنها تشمل أشياء كثيرة، ممكن يعني عديدة، منها ميديكيشن، منها هيربال، وممكن أشياء ثانية تتعمل. يعني we're not gonna go into the details. Now the studies says إنه what I discussed in the management, this is the evidence based. The other, I'm not saying that they are not as good. There could be, but there is no evidence that they are. I will give you example. Some people say, okay, we give gluten casein free and the child is stopped from being hyperactive. I said, fair and good for your own child, but I cannot say for the other children. Because really, when we come to the individualized effect, is different than the statistics effect on thousands and thousands of people. So from our point, when we recommend something, it has to be evidence-based, that is been under control. Does the parents want to try? I don't usually prevent them, as long they are not doing the alternative and they're not doing the evidence-based. Let's do the evidence-based, we add to it. And I think maybe the only thing that I will mention is omega-3 here. Because there is good studies about omega-3, but not to reach statistically difference in the symptoms of ADHD. But does omega-3 make harm? No, as long as they take it in the right doses. So some of the alternative, it can be done, but is it evidence-based? لا ما أظن. We have to, as medical personnel, انتبهوا ترى إحنا إلينا كلمة قوية، ما نقدر نقول الكلام اللي يقوله العامة. أوكي؟ فإحنا لما نيجي نسوي counseling إلى البيرنتس you have to really be clear of what you're talking, because كلماتك لها ثقل كبير, and you give them what is right and you discuss other things if they want. And I don't come say, oh, you could use casein, gluten or low sugar. No. لا, هم إذا سألوا أنا أجاوب عليهم بالعلم إيش يقول. Okay? Did that answer you, حبيبتي? Okay, very good.
Okay, so we will go to break, and please come back here about 9:50, and we will have 2 more lecture, and then we'll break again. Thank you.
السلام عليكم. بعد البريك بيكون في إن شاء الله محاضرتين، محاضرة بتكون هنا في القاعة ومحاضرة في القاعة بي. طيب إذا الجداول عندكم بتعرفون وش المحاضرات. طيب المحاضرة اللي بتكون بقاعة بي بيكون للأستاذة بسمة الحلمي والأستاذة مروة. طيب ففي محاضرات بالعربي بتكون بالقاعة بي ومحاضرات باللغة الإنجليزية هنا إن شاء الله.
سنة وشوية عليها بدري سنة ونص.
ايوه. مو انا المسؤول. لا ما اعرف، اسال الدكتوره، في الدكتوره سميره الماضي. السلام عليكم ورحمة الله وبركاته. We should resume our session. It gives me a great pleasure to present Dr. Samir Al-Muhammadi, our colleague. He's a pediatric neurologist and epileptologist who work in a military hospital in Riyadh. He had done his training in pediatric neurology and fellowship in sick children in Toronto. After the Saudi board in pediatric neurology, and also had done a postdoctoral research scholarship from the University of Toronto Center for Neuroscience and Mental Health. تفضل دكتور سمير.
طيب, thank you Dr. Saad, and I would like to thank the organization committee for this. I will talk about cerebral palsy from neurodevelopmental perspective, but as you know, like cerebral palsy is a very huge topic with a lot of things interacting to reach like a normal development. And I will talk about peculiar things related to our country. So I will start with brief introduction, obstacle to success in management of cerebral palsy, and the evidence-based interventions. So cerebral palsy is a very heterogeneous group of disease. The main feature of those diseases is non-progressive disorder. So any progressive disorder is not related to cerebral palsy. It's mainly affecting the muscle, posture, and movements. If you go to the timing of insult, we are talking about the prenatal period, before perinatal and postnatal, with most of our like insult happen in the prenatal periods. The epidemiology worldwide, it's two per 1,000 live birth, and usually the preference is more when we talk about in the preterm in comparison to the terms. And usually the main two risk factor for cerebral palsy, there is multifactorial, but the main two are the weight and gestational age. So anything below, if the child is born below 30 weeks, he has 60% risk of having cerebral palsy. And if we go to the patient less than 1.5 kg, we have almost like 80% risk of the child having cerebral palsy. So those are the main two risk factors. How about the kingdom? This one done in 2006 about the incidence of cerebral palsy in our country. It was like a small study, but there is interesting finding. So our incidence is a little bit higher than worldwide. So we have like he discovered like it's like 4 in 1,000. But the really interesting way, if you go to the over time, you can see, I think this is more, if you can see the incidence of cerebral palsy in the kingdom, it's going down from the 80s up to the 2003. And you can see like the percentage is really huge. It's almost like 10% or 1% up to until we reach like less than the national figures or the global figures. You can see the types. We almost like initially we have almost all the types. Spastic type was the most dominant, but currently most of the time, like 80% of cerebral palsy we see in the clinical practice are related to the spastic type. This is the same. So what's the obstacle to we face in the managing patient with cerebral palsy? We usually take it from three perspectives. From the clinical perspective, the complexity of the child. Cerebral palsy is not only motor. It's a motor with huge complication. We have seizures, global developmental delay, spasticity, feeding difficulties. So this is from clinical perspective. And the worst part, and I think from the system perspective, how the family navigate the healthcare system and provide the best care for the child, especially like if the child live in area outside cities that provide tertiary care. And as like my colleague before, when we have like very limited resources for ADHD, we have very limited resources. Like in the kingdom, the well-developed rehabilitation center only in Prince Sultan humanitarian cities and in King Fahd Metro City. There's small rehabilitation like in King Saud and other hospitals. But I will focus mainly on three related to our cultures, is the misconceptions, unmet needs, and the correct diagnosis and evaluations, which is really like very peculiar to our country. So I will start with misconception. In every clinic, we hear a lot of misconception related to the cerebral palsy. It's a progressive disease. Most of the family think the child cannot live independently, and a lot of them, they think like they cannot communicate, they will be crippled, and a lot of them, even the source of the diagnosis, they related either to evil eye or jinn or whatever. So there is a lot of misconception related. And if you go to the main theme of most of the family, and the child like cannot live independently, and if you go to the CDC, you can see like almost like around 60% they can walk independently. With a lot of people, they can go with, like walking with aid. And I will come to this at the end when I talk about like how assisted or augmented support can improve the quality of life in such cases. This is a study done recent in 2018, so it's a recent study. It's not old, about the perception of disability among mothers with children with cerebral palsy, and it was very interesting finding. So they related to three interacting misconceptions. So we have cultural belief in evil eye and jinn, and then we have the community stigma and discrimination, which a lot of them, they have like social barrier isolations. And we have the motherhood and disabilities. How the impact of the child, not on himself and the healthcare, but even on the family itself. And just to give you a few, like from the study, you can see some of the comments from the mother. So the first mother said, I believe what happened to my son was a strong ain, evil eye that hid his health. I felt it was one day when I had a large gathering in my house, and one of the ladies, without saying mashallah, said, you have a pretty child. It's very common in our clinic. And this misconception, if you don't correct it, it will interfere with your management, because with faulty misconception, you will not be able to address the need. And the other, deep in my heart, I felt it's jinni that caused my child disability. I went to traditional treatment, which is most of our patients go to. There is very few traditional, like I'll call them therapists, in our community, very well known, like in my region, like in Medina Munawwara in the south, very well known. And most of our patients, they went to them. And to be honest with you, the first time if you face the child from the beginning, like even after birth, if you suspect the child will have cerebral palsy because he has HIE or anything, usually our dynamic is a little bit different. So the family, they came with you, and they want the child to be a normal child. So they have a perception like the child will be normal from the beginning. And they will go to the grieving cycle multiple times. I said, it's not one time. So initially they think the child will be normal. And as his developmental progress, they found the child is lagging behind his sibling. So then this conception, and the most important things, is my child gonna walk? So this is the main things. Then a little bit until we reach the point that the child mainly he needs like palliative care. So you can see the family, they go through a cycle of grieving with each one step of them. This is, I found it very peculiar in our daily clinical practice. And we have usually addressed it to them. Another unmet need, I will go to few of them. So you can see like We have pain, we have intellectual disability, non-impotence, we have seizures, behavioral disorders, incontinence, sleep disorder, blindness, and very a lot of unmet needs. I will go to this one. We said unmet needs and healthcare utilizations. And you can see, like, if you go to the rehabilitations and the number of, most of them, like, they need a lot of specialties. They estimate, like, cerebral palsy patient, how much, like, especially like the severe one, they need up to 14 clinics per year. So imagine how they can coordinate it. And there is a lot of them, they have, like, they cannot see all of them, all of the subspecialty needed. And you can see the domain score and how much they meet the needs. Usually those with severe cases, they have more needs, and that's not met. This is when it comes to rehabilitations and healthcare professions. Most of our patients, like a lot of them, they don't have enough facilities that facilitate their needs. Then one major obstacle is not even during pediatric, but even transition to adults. And this was a study, are the health needs of young people with cerebral palsy met during transition from child to adults? And I can tell you from personal experience, even like in epilepsy, when we transition an epilepsy patient from adult to pediatric, we struggle in terms of how much the adult epileptologists have more keen or more mastery over knowledge over the pediatric complication. So, and because we have like a younger, like we usually transition happen in our pediatric from 12 to 14, we have struggled with them. And you can see, like, when they ask about the daily living or healthcare, most of their need is not met, even you can see at baseline or even at different sequence of visits. So most of them, they are not met. Let me go with this one. This one is very interesting, done in King Fahd Medical City. They said malnutrition is very common in our cerebral palsy patients. It's up to more than 50%. So it's really, really huge percentage of our cerebral palsy are malnourished. This is related to many facts, but one of them, like a lot of our parents, they don't have been educated about like GT or other nutritional. But you can see with this malnourished, a lot of complication like bone health, they're predisposed to more fractures and more complications. This is like exercise. This study done about the exercise and physical recommendation for cerebral palsy and how much they need. So we can see percentage of time spent in sedentary, light, or moderate. Most of our lives are really, even like those with mild cerebral palsy, they are mainly, most of the time, they are bed-bound. And if you go to the physiotherapy that our patients receive, usually they receive one session every 2 to 1 month. It's really not enough. Usually these at least 3 to 4 sessions per week. I will tell you about this is one of the cases that come from the periphery, and I will tell you a lot of I think most of our neurologists, they face the same things. So this is a 1-month-old boy referred with cerebral palsy. See, and you can see the age is only 1 month. It's too young to be to be labeled as cerebral palsy. He just joined us at birth, and his Apgar score was almost like fine with blood gases. However, it seems like he has progressive spasticity. This is a very common pitfall in diagnosis and evaluation of patients with cerebral palsies. And usually in our hospital, we catch almost like one every 2 to 3 months, especially if those referred from our like peripheral hospital to our like tertiary care. And this case was, there's two things you have to question yourself when it comes to diagnosis of cerebral palsy. If the age is very young, like in such cases like one month, and if you have no clear risk factors, so the child is term, Apgar score is fine, blood gases is look okay, then think of metabolic disorders that mimic cerebral palsy. It's very common in our society, especially like in some area we have like consanguinity up to 70%. So the average in the kingdom is around 54, but it's mainly in some like especially in the north and the south, maybe it reach up to 70%. This is really interesting paper written by one of my colleagues, Dr. Wajdan, and she summarized them in very nice way. So you can see there is some disorder with prominent spasticity, mimicking spastic cerebral palsy. There is some with prominent dyskinesia, with like the dyskinetic type, and some like even mimic the ataxic type. And why important to diagnose them? They have two things. We have some treatable metabolic disorders. So if you tackle them early, you can improve the child's neurological function and developmental function. So this is one of major things. Then our kids are found to have a genetic diagnosis of autosomal recessive hypermethionemia due to adenosine kinase deficiency. This is very important because if you miss this child, you can, like even this will be the index case for his family. And if he was the first child, so later on when we screen both parents were carrying the type, and this has huge implication in planning the pregnancies. So if the child was missed as a case of a cerebral palsy, usually we'll miss the parenting or genetic counseling, and usually if the child has treatable metabolic disorder, he will be missed. So this is mainly like the challenges we have. So when you go to the treatment, it's really not one phase or one specialty that can take over. So at least they need maybe up to 10 subspecialty. We need like neurologist, rehabilitation, physiotherapist, GI, and rehabilitation. This paper is really nice. It states the evidence. It's what's really interesting. It's gathered a huge amount of studies and try to summarize them in a very evidence-based. And I really recommend everyone to read about it. If you go to the end, they include almost like 124 systematic review, 25 randomized controlled trials with some other studies. So what they found, you have to have a framework for treatment. So without framework, usually the child will get lost. So there is a huge number of intervention, and you'll see later, like most of this intervention is not evidence-based or have very weak evidence. And usually we have to mitigate the natural history of cerebral palsy. Cerebral palsy is not a progressive disease, but if you neglect the child, you will have more spasticity and more progression, not because of the disease is progressive, but the child neglected and there is no supportive. And usually if you don't have an active dynamic like treatment, usually we end up with secondary impairments. Usually, and this is really like the most important things, what the family perception about the disease, what the perception of the outcome. Usually, and I found it here, like most of the family, once they reach a point of losing hope, usually they will abandon the child. So the child will develop more contracture and more complications. So family have to be educated, and like a goal of treatment or outcome is really stated. So what's the domain usually we have to improve? So all those domains like interact with each other to improve the neurological outcome of any patient with cerebral palsy. So we have impairment, and with the impairment, mainly we focus about the motor function, so the gross motors, the self-care, what we call it the fine motor function, speech and communication, the general health, quality of life, when I come to this in a few things, interaction and participation in the society, which is mainly neglected in our cases, and usually the caregiver quality of life. So if you go to you can see the number of intervention. It's really huge number of intervention that this study evaluates. And usually those in green are the one with strong evidence. The one in orange, it has weak evidence or there is no benefit, while those in red, they don't have evidence at all. So the one with green is bimanual training for hemiplegic cerebral palsy, constraint-induced movement therapy, context-focused, goal-directed functional training, and occupational therapy, especially for the upper limb for fine motor skills. The Waker home program is always and usually exercise. Usually because when the family came to us in the clinic, most of them, I'll say not all of them, but most of them, they have like underutilizing of rehabilitation. They have less exposure to rehabilitation. So we mainly instruct them how to do it at home. And usually we find good results, especially if the mother is trained with different session of PT to do those things at home. So it's really effective way of interfere. There is one thing getting more and more attention, but unfortunately there is no evidence. What we call neurodevelopmental therapies. It's very common in the if you go like in the media, but unfortunately there are no result. Well, we call it POPATH treatment. POPATH is one of the German neurophysiologists. So this is done a systematic review exploring is the treatment, the neurodevelopmental treatment, it's just like a physiotherapy with more details like about posturing and different things. But unfortunately, when you compare these methods to the conventional physiotherapy, and you can see like most of the studies favoring the conventional physiotherapies. Let me go, I think I'm stuck. So this is for the weak evidence, like animal-assisted therapy, especially horse, when riding horses, assistive technology, and conduction. One of the things like I found like our family is really like not peculiar to cerebral palsy, but most of the neurodevelopment is the hyperbaric oxygen therapy. A lot of them, they travel outside to do it. And unfortunately, I would say there is no evidence, zero evidence about it. I found patients with cerebral palsy, autism, yeah, usually those main people they go to it. I think you have experience with this one. So it has no evidence. Whenever the family came to us, usually we don't recommend it to be done. So when we come to this spasticity, we have the oral medication. Usually we start with them, especially baclofen. We have dantrolene, benzodiazepine. We have other agents. Some they have the intrathecal baclofen pump, and we have selective dorsal rhizotomy and deep brain stimulations. So the pump usually it's similar to the insulin pump, but it's delivered the baclofen intrathecally, and usually it have direct impact on the neurons. And also we have selective rhizotomy when they cut a few things just to decrease the inhibitory from pathway from the upper motor neuron, from the cerebral cortex. And then we have the new, which is I think available in King Faisal, which is the deep brain stimulations. Usually the deep brain stimulation is mainly with like aesthetic, with dyskinetic, or with abnormal movements. So we finish with this one, and we'll go with the general health. I will not focus, for sake of the time, I will not go with all of them. Maybe Dr. Ali is not here today, but epilepsy is the main contributor factor. So this is a very nice study done about 10 years follow-up. So they evaluate the IQ about like 10 years differences. And what they found, you can see that time 1, the full scale, and there is a decline in the whole things over 10 years, and like the main difference in the IQ of the children, usually it dropped down. And when they sub-analyzed those patients, they found like mainly decline if you have history of seizures. And usually the cognitive decline over times. And if, just to give you one thing, if you have, so this study shows if you have more seizures, usually you have decline in the IQ. But on the other hand, we use anti-epileptic medications, and anti-epileptic medication is not benign. So if you go with the phenobarb, it can cause cognitive decline. So the first line is the corrected score, and if you go with a dose, so the more dose the child has, the more have impairment in cognitive decline, motor decline, and even in the language. So it affects all domains. I know like a lot of people think Keppra is benign. It's benign than phenobarb, but still you can see there's statistical significance in decline. Just to give you impression how much cognitive decline will impair with phenobarb, in the 90s we used to use the phenobarb for those with febrile seizures. And when they compare it over 2 years of age, they found like children with phenobarb, they have 6-point decline in their IQ. This is for normal kids. So imagine like if you have a child who's developing a younger age with abnormal brain, the impact is usually more. So now the practice in the neonate, especially like we found like patients referred to us from outside, usually they are in phenobarb for a long time. Like the child will have seizure at birth in the first 24 hours, which is clearly like symptomatic seizures due to HIE, electrolyte disturbance, and then the child put on phenobarb for the whole years. So now the practice completely changed. Once you have symptomatic seizure, especially in the first week of life, once the seizure is subsided, you have to stop the anti-epileptic medication because they are not benign in nature. So the difficult part is to balance between how the seizures affect the cognitive and how the medication, and usually it's done in patient-to-patient. So I will go with pain. Pain has very important role in mainly quality of life. And pain is really, we ask about it in the clinic. So I think usually we ask him, how's the spasticity, we examine him quickly, but we didn't focus much on the pain. So usually those patients with cerebral palsy, they are more sensitive to pain. They have higher prevalence, intensity of the pain, and they have greater impact in their life. In one study done in Europe, a cross-sectional study with patients with cerebral palsy, they found 60% experienced pain in the previous week. So if you ask 100 patients, like we have 60% of them, more than half, will have pain and acute pain. And usually parents, if you ask them in the previous 4 weeks, almost like 3/4, like around 75% will tell you there is pain. And usually the problem with this, as the neurological impairment increases, usually the prevalence increase. So in patients with ambulatory, they have around like 48% will have pain, while those who are not or bedridden, almost like 80% they will have pain. Pain is very prevalent, and usually one study showed like if you decrease pain by 1%, it will contribute significant impact in their quality of life for those kids. Another thing that is really interesting, like the augmentative and alternative communication, which has become more and more. This is study done in how like adults with cerebral palsy benefit from those devices. And if you can see, we have like almost the age of like patients in their 30s and 40s. There are different type of cerebral palsy and different disabilities like hearing, difficulties and others. And most of them are well-bound. Few of them, they are able to walk. But if you go to their level of education, it's very high. Like most of them, they have masters. There are some colleges, bachelors. What's really striking me if in this study is not like how like academic achievement those patients were able to achieve, but it's the amount of work they are able to do. Sorry. If you go to the working hours per week, those patients, some of them, they work more than us. So they work up to 40 hours or more than 40 hours per week. So those patients, if they are given the chance and the support they need, usually they will be very high functioning. And one last thing about parenting style, and this is we notice it in our practice. Usually the family is overprotected. They isolate the child. Whatever the child needs, usually he said, just sit down, relax, we will help you. And this study was very interesting. So they said the parenting style impact the quality of life in children with cerebral palsy. What do you think the most important factor like improve the quality of life? Being autonomous. So the more autonomy the parents give to the child, the better the function he has, which is really impact one of the things we're lacking. So usually we tell the family, just give him the chance, He can do it. And usually parenting style is a very significant factor in quality of life in cerebral palsy patients. And usually the only factor known to impact the psychosocial domain exceeding the effect of the disease itself. So imagine like those, and because the quality of life is an important goal, early family intervention and focusing on the style of the parenting it has huge impact on the child and his quality of life. So in summary, management of children with cerebral palsy require a very collaborative approach. Multidisciplinary teams has to be involved, and usually family has to be up front to maximize not only the neuro, but also the social, emotional, and communication educations. And usually those children, if you give them a chance, they can be highly functioning members of the society. And this is conclude my talk. Thank you so much.
Thank you, Dr. Mohammadi. I will open the floor for 2 questions, and then we'll go to the next lecture. Any question?
Yeah. Yeah, sure. Yeah.
Thank you so much for this informative lecture, and you've pinpointed some details that we really have to focus on. I do have 2 questions, honestly. You mentioned that around 56% of children have malnutrition when they have cerebral palsy. Now, I worked with the neurodevelopmental for a long time, since 2003, تقريبا 2015, and we usually tell the parents to keep their weight anywhere between 10 to 25%, because it's easy for them, especially the severe one. So is the malnutrition status that you're talking about, is it because of the weight and height, or really it is the biochemical part that they have malnutrition?
So I know like usually those patients are thin, but in the study, when they go to the measurements, like the different measurement for the fat and those things, and they found like this is below what's expected from them. So the malnourished is really, they are sensitive in terms of like they are not what they're supposed to do. Like they are below the average of what was expected from those children.
I understand, but is it like meant to be that way? Because we intentionally don't want them to be overweight. If they are 50% and above, it is really hard for especially the severe one to be taken care of. You need to carry them and so on. So we intentionally put them on a half to two-thirds of their caloric intake to keep them in anywhere between 10 and 25, as long their albumin, their calcium, their vitamins are all normal. So I'm not sure if this malnutrition is bad or not bad for them.
But what in the study was like, those mainly like they have certain parameters. They judge it as if the child didn't achieve those things, they consider it as the malnourished.
Okay.
I'm not sure about the details, but this is what I get
okay.
from the study.
Okay. The other question is the premature kids. We know that sometimes if the prematurity or the premature labor happens because of the child factor, not the maternal factor, that there is a lot of good now recommendation to do more genetic workup on these kids to find out if the child himself or herself are the reason for the prematurity. So is that part of what you went through in your research?
No, so the prematurity by itself. Nowadays we have like clear, like we call it in the premature kids, we have a clear predictor in the term of outcome. But usually for genetic testing, usually we don't do for them. So if the child is premature, have clear risk factor like low birth weight, low Apgar, cord pH was very low. So all the risk factors, there is no need for genetic workup. Genetic workup usually if the child if the mother has multiple, multiple children with the same things.
Yes.
If there is family history, and if the clinical presentation is very weird, like you have very smooth pregnancy, you have very smooth perinatal period, Apgar was fine, and then the child he's lagging behind, especially in terms of motors, then we think about genetic testing.
I think there is a new recommendation that sometimes if there is no explanation for the prematurity, that we need to find out if there is a fetal factor really.
Yeah.
But thank you so much. That
thanks.
was really informative.
Thank you.
Excellent. No further question. We'll conclude.
Thank you.
I will actually add one comment. It is a huge resource for kids with cerebral palsy because they usually have more motor than cognitive is جمعية الأطفال المعاقين. And they have many centers in different cities in the kingdom. And they usually provide a decent services to these kids. So if you have a kid, refer them to these satellite center for الجمعية, and they usually evaluate them and provide services, and usually multiple services: speech, physio, social, occupational, and usually provide them also some supportive equipment if they need to. Prostheses, they usually have also a referral to pediatric neurologists. So they do a decent and excellent job. Thank you.
Thank you.
So with this, we will conclude.
Thank you.
شكراً دكتور محمدي. It will give me great pleasure to introduce Dr. Fawaz Al-Anizi. He is a developmental behavior pediatrician at King Fahad Hospital. He's the head of developmental and behavior pediatric and chairman of Child Protective Community. He is the leader also of developmental and behavior pediatric services in Riyadh Health Cluster 2. So تفضل دكتور فواز.
بسم الله الرحمن الرحيم. Good morning everybody. My lecture is before the break, so probably you are a little bit tired from the morning lectures, and I thank you all for being here. It's my pleasure to present this topic. Actually, it is a big topic. It's no way to cover it within 25 minutes, but I would like to highlight some very important point in this topic. So it's so important for our brain to be mature and to able to achieve developmental skills to get an information from environment, either the external environment or our internal environment. Is that so important to interact with our world to build our ability to achieve the skills in appropriate time. So, and to get this information from environment, we have 5 primary senses. The most major sensory system, it's the visual and hearing system. So we are going to concentrate on that today. It's not only important to get the information, also it's help the child to be motivated to explore their words and to interact with it. So hearing, this is the classification of hearing. We have mild, moderate, and severe, and profound. And that's so important because much more severe in hearing impairment will have and risk for developmental impairment. We have 3 types of hearing impairment. We have sensory neural and conductive hearing loss and the mixed type. Usually the conductive type is milder than the other because it's the sound louder than 50 decibel, it's conductify temporal bone to cochlea. So epidemiology, that's actually it varies according to the region and the classification. For the cases estimated in USA at the age of 5 years, for cases more than mild hearing loss, estimated to be 2 to 3.5 in 1,000. It means 0.2 to 0.3. And for the milder cases, it's 10 times this number. So it's quite common for mild case. It's reached 2 to 3%. In developing countries, this is estimated to be double this number. Why? Because of their accessibility to the health system. It's less than the developed country. So we have the infection and the recurrent otitis media that lead to conductive hearing loss. The etiology, we have the genetic cause, it's the majority. It can be autosomal dominant, autosomal recessive, which is the common, and X-linked. One of the commonest syndrome, it's Bend-Red syndrome. It's 4 to 10% of cases with hearing loss, and that's usually manifested by goiter and cochlear malformation, in addition to sensory neural hearing loss. The acquired case, it's around 35% of the hearing loss. It's prenatal, it's like maternal infection, rubella and others. Exposure to toxin, also like alcohol or drugs. Perinatal, the prematurity is a play factor here, so it's not the prematurity itself, the complication of prematurity, especially of low birth weight child. So some drugs like aminoglycosides have an effect on hearing, as well as other toxins like hyperbilirubinemia, which is so severe to need exchange. Postnatal, like otitis media and infection, here like meningitis, and estimated to kids who's having Haemophilus influenza meningitis to have around 7 to 8% of them, they have a complication of hearing loss. So that's so important to do screening for these cases. Trauma and tumor, prolonged exposure to loud noise like music, it can affect also the hearing. So how much the hearing impairment affect the development? That's actually vary according to few factors. And one of the most important factors, the degree of the hearing loss. The mild cases is little risk to have developmental delay. Etiology for the hearing loss also play a role here. So genetic cause, usually with better outcome. Why is that? Because the diagnosis is usually early, and the family have some experience how to deal with this kind of impairment. Age onset of the hearing loss, also it's important, and that we consider it when we do some procedure like cochlear implant. It's so important to be done before the critical age, which is 2 years. Comorbid disability, if the kids having isolated hearing loss It's not the same the one who's having another disability like vision disability or intellectual disability. So also the family climate, how much the family engage the child in their environment, how to find the way to communicate with the child, also to play a major role here. The timing for intervention programs and to start with the child also is essential to achieve optimal outcome. So how much that affect the development? So what do you think? What's the most domain affected by hearing impairment? Yes. So the language communication, it's per se, let us say the language is more affected by hearing loss. And it's found that the deaf kids, the problem not to hear the sound, also their ability to build their language, it's affected. And also they have problem with the higher language, for example, to translate their experience to an spoken language. So they have difficult with that. So even if you interfere early and put like cochlear implant, their ability with high language still, let's have some impairment here. Identification before 6 months, so higher language development. Cognitive, what do you think about cognitive? Is it affected by hearing loss? Actually, there was a debate about that, and we have challenges here. How to assess the kids with hearing loss? Is the usual IQ assessment is accurate in them? It's not that accurate. So, but we have two parts for the IQ. We have the language part and we have the performance part. Usually the performance in the kids with the hearing loss, usually within the normal as the other kids. There was a lot of debate in the past about the cognitive with the kids with hearing loss. But nowadays there is almost agreement the hearing loss or the deafness per se, it's not affect the cognitive, unless they have some other factors. Yes, they have some problem with the cognitive flexibility and language ability, but that shouldn't be affect the basic concept of the cognitive. Social achievement usually is delay and usually lower in deaf kids. It's estimated that the kids with deafness at the age of 18 years, they perform like normal kids in the 4th grade. That's mainly in the reading comprehension, and the math estimated to be at the 7th grade. Social emotion, it has some effects here, and that depends on the opportunity to usual social interaction. Usually it's limited with deaf kids. Why? Because they have language communication problems, and also the parents tend to be more protective. Their personality is found to be ecocentricity, and so they have some rigidity personality. The deaf kids more having of aggressive behavior. Why? Because they cannot communicate and express themselves. The deaf child are likely to initiate more physical contact. There is a problem with attention, impulsivity, or the kids with deafness. Usually no, but if they have, that depends on the cause. Like for the kids who's having deafness due to rubella, maternal infection, they found to be 25% of them, they have conduct disorder, and also 40% they have impulsivity and hyperactivity. So management, it's so important to the identification here, and then we'll go for a diagnosis, medical assessment, then developmental assessment, and early intervention, then the education, school services, community, vocation, and their rights. So screening, nowadays, you know, there's universal newborn screening for hearing loss, and that is so important that play to reduce the average of diagnosis from 30 months to 2 to 3 months. And most use screening. It's the evolved autoacoustic emission testing. It's so sensitive testing, although there is a false positive results. All infants who's having risk indicators for delay onset and or progressive hearing loss should be regular assessed for hearing every 6 months till the age of 3 years. The physician, they should have low threshold, refer to audiologist regardless for the risk factor, also regardless the newborn screening, especially if they have concern like speech delay. CDC goals, but goals, it's called 136 goals. It's screening before 1 month, and then the diagnosis before 3 months, and start early intervention program before the 6 months. This is the risk factor, so I'm not going to go over it, but as you see here, ototoxic medication, this is a message for our colleague, physicians not to use ototoxic medication like aminoglycoside in ICU. So medical treatment, routine screening, and refer to early intervention program, it's so important. Refer for ENT, ophthalmologist, genetic assessment, developmental pediatrician, audiologist, so need a complete assessment. Hearing aids or cochlear implant, and that should be done without delay. And the role of physicians, it's have an important as educator, not only for the family, also for the community regarding special need of this kind of population. Cochlear implant, so if we have time, we'll just highlight some few points about the cochlear implant. It's now it's used more than in the past, and it should be selective for kids who's having bilateral sensory neural hearing loss, who have shown little or no benefit from hearing aids. Associated cognitive and behavior problems must be considered, and the family committed is so important here. So if the family is not that committed and to engage the child and support him, probably the benefit from cochlear implants will not be that optimal. The study showed there is significant long-term gain in receptive and expressive language. So developmental intervention for kids with hearing impairment. Early language experience, particularly linguistic intervention with parents from early age is critical. Also, they should expose to diversity of experience. That's also very important for them. Social intervention will help to increase their cognitive function and to develop basis exploration that will help in their self-esteem and motivations. Nowadays, it's prominent to use an approach of total communication. What does that mean, total communication? That include a verbal language in addition to speech reading. Also to use some manual communication like sign language. So education should be assessed first, the child, and a multidisciplinary team that will include the physician who is expert in hearing loss, also speech and language therapist, audiologist, and educator, to put a plan and to develop an individualized education plan with special. So here there's so many debates about, is this child need to go to special education and special school, or should be in the mainstream public school? That's each of one has some benefit and disadvantage, and that should be assess each child per himself, so alone. So put a specific plan for each child when take in consideration how much ability of the child himself, and second, also the resources available in the school. And the third thing that's very important also is the family support. If they get maximum support, of the family committed to support their child and to interfere and help them, they can go to a mainstream public school. So that's about the hearing. Now we go to the vision. So the classification of the vision impairment, we have the blindness, which is total blindness. That means vision acuity, it's worse than 2/400. That include no light perception. Legal blindness, which is mean the best corrected distance visual acuity in the better eyes, worse than 20/200. Also, there is defect in the field. Low vision, it's that refers to a child who's having visual acuity between 20/70 to 20/200. Why we need to classify like that? To see whose child need to support from the government and the community, and to know also how to deal and to develop an intervention and education plan for this child. So etiology, we have prenatal, perinatal, and postnatal causes. Now, nowadays in the USA, the most important three causes, it's the CNS condition, one, and the second is the retina prematurity, and the third one is optic nerve dysplasia. Okay, so identification. It's so important to, it's not only the responsibility of pediatrician and family practice, also all the health practitioners should be responsible to detect these cases early and to refer for ophthalmology. We have a routine eye screening that include observation of child use vision, also obvious ocular abnormality, visual fixation, observe pupillary response, and distance visual acuity. So recommendation of CDC, they said at least 4 times the child should be checked for eye exams. That's in the age from birth to 6 months. Also the second one from 6 to 12 months. The third one from 1 year to 3 years. The fourth one from 4 years to 5 years. Then the subsequent will child visit. Ophthalmology referral, we have to, if we have any concern or this risk factor, that should be referred to ophthalmologist, including a failure to fix and follow the target by 3 months of age, abnormal eye alignment, ptosis, nystagmus, abnormal visual acuity. So how much that affect the vision, how much it will affect the development? What do you think is the same as hearing or more or worse? Which domain is affected mainly? Fine motor. The second domain is affected. Any volunteer? So the most affected 2 domains. One is the cognitive, and the second is the motor in general. We'll talk about it. Like here, there is some factor play major role about how we can estimate the impairment of development. One is the severity of vision impairment, and the second type of visual impairment. Third is comorbid disability. The child who's having, and actually the blind or severe vision impairment child, they tend to have 50% and more of them, they have another disability like hearing impairment and autism or intellectual disability. Intervention and experience, that's also play a role here. So early detection, it's we can prevent some preventable cases, and it's lead to better outcome, better academic achievement. So the cognitive, generally the cognitive is affected by vision impairment, and the more severe, the more effective in the cognitive, because there is a delay in acoustic fundamental cognitive concepts, and also they are not motivated to explore their world because they cannot see. Age of loss of the vision, it's also important here, because usually the establishment of vision memory, it's approximately at 5 years. So a language, what do you think about the language? Is it affected by vision impairment? Generally, no, so it shouldn't be affected, although they have some problem in adjunctive and verb and pronoun. They have some prolonged echolytic speech phase, and they have some problem, some concepts like colors and size. And subhanAllah, they with spontaneous, they learn something we call it echolocation. So from the sound, they can estimate the distance of the object, also some character about the object, around the size and what materials of this object. Play, it's also affected because they are not so motivated. Also, they tend to have to play solitary, and usually it's delay 2 years behind their peers. They need a guide to play, more interactive, more skills they can gain. We can provide them with toys that are interesting for them, like tactile toys. Also, there is some auditory sensory things. Social skills, usually it's less than or delay than their peers because of their, they cannot express, the social cues, it's sometimes impaired. So how to express their self. The parents have difficulty to understand their child, especially it's like social smile. They are not smile in the way that usual kids smile. Behavior and emotion difficulties, they have so many emotion reactions, difficulties. And they should be taught about about reciprocal reaction and emotional reaction. Motor skills, we said it's the second domains affected, the motor skills. And usually the early motor milestones not affected, like sitting, rolling, that should be often the same timetable. However, the movement in the space typically delay. So they need somebody who's specialized to work with them, to they can get the better outcome. We call the certified orientation and mobility specialist. They teach the child about their spatial arrangement and their environment, also to develop their own mental map. And always we ask the parents not to change a lot in the home furniture for the blind kids, so they can develop their own mental map and use the knowledge more for efficiency and safety. So management, as for the hearing loss, we have the identification, diagnosis, medical assessment, developmental assessment, early intervention, school and community, and then their rights. So developmental assessment scale, we use so many scales for developmental assessment. What do you think about the scale that we use? Should we use the same scale with the normal child for the blind kids? Yeah, so the scale that we use for normal kids, it's not accurate with blind kids. We have to modify it or adapt more changes in the scale. Mental health assessment also, because the blind kids tend to have, it's not that active and more isolated, so when you assess their mental status, you have to take this in consideration. Behavior and social skill is to regulate the social interactions affected, like social smile, facial expression, so should be taken into consideration. So autism and visual impairment. What do you think? Is it easy to assess child? It's very difficult to assess. Why is that? Because the blind kids tend to have some mannerism, motor mannerism, so they have hand flapping, that's common to them. Also some body rocking, and they can also press their eyes. They have some sensory issues, a lot of sensory issues actually. In addition to that, they have, as we said, they have some difficult for behavior to regulate their social, like facial expression. Also the social interaction with the other kids is impaired. And this is basic things when you assist the kids with autism. So we need somebody who's expert in blind kids to diagnose them for autism. It's not only that, they should given a time. So we will not diagnose them immediately at 2 years of age. You have to wait till they develop more significant symptoms, and you can differentiate between the two. And however, it's found that the blind kids tend to have autism more than the other population. It's around 15 to 25% of child with blindness, they have autism. So early intervention program, it's so important to start early, and should be include designed by multidisciplinary team approach. It should be individualized according to the child, so each child has a different plan. Ophthalmologist, OT, speech therapist, psychologist, social worker, and parent advocate. This is the stakeholder, or the should be included in the multidisciplinary team. Certified orientation and mobility specialists. We talk about this and their job. So school age child with a blindness, they should have an individual education plan, and there should be a certified teacher who is expert with vision impairment. It's so important to consider transition and mobility in the school. Some use of other language, اللي هو لغة braille instruction for a student, and they should access. They need more resource in the school, like a large print, some boxes, low vision devices like magnifiers, and other technology like digitals. They need ongoing assessment, and they should integrate with non-disabled peers, that with some caution. So, summary. The profound hearing loss and blindness is rare. However, the mild degree is common. The genetic play a major role in the causes. Hearing impairment poses significant challenges in language development, social emotion, and academic achievement, while the vision impairment affects the cognitive and motor domains more. Prevention is so important here. We know it's for the vision impairment, 40% of the cases can be prevented with treatment and diagnosed early. Multidisciplinary team approach for each child. Medical treatment include cochlear implant and surgical for eye problems corrections. Physician and health professionals' role in these cases so important, and you have to advocate behind your child and the family. So thank you. Any question, please?
Thank you, Dr. Fawaz. We can take 2 questions.
السلام عليكم ورحمة الله. Dr. Fawaz, thank you very much for this lecture. My question is why cognition is affected in vision impairment? Why it's more affected than hearing, in hearing impairment? Why cognition is affected?
I don't think I get your question, but I think you are asking why the vision or the vision impairment child is affected more than the hearing?
Yeah, why cognition is affected?
Cognitive, yeah. So, as you know, to cognitive, we have basic concept, the initial things like cause and effect, and to explore your environment, to get more information. It's not that accessible for kids with vision unless we have some help. And actually, I'm not saying the whole kids of blind, they have problem with cognitive. We talk about the risk factors like the severity, and if they diagnose early, if they have family support, and if they have no other problems like hearing problems or intellectual disability. And also, we know that 50% of the kids with vision impairment, they have other problems. So that's why they tend to have more cognitive problems. I know we have some examples in our community with vision impairment, and they are so smart, but that's unique cases. Should we to not generalize for the whole kids?
Thank you so much, Dr. Fawaz, for this comprehensive, really, overview of the visual and auditory and hearing disability. My question is, during your research, did you find kids with a visual disability and dyslexia? I know this sounds very, very unusual, right? Because dyslexia, usually you think about it for people who can see. But did you come across visual disability with dyslexia?
Actually, there is no specific things, but we know most of the cases of dyslexic child that you have to assess the vision. So they have mild impairment, so that can affect your diagnosis for dyslexia.
No, the reason I'm saying that, I have actually 2 kids who are with the visual disability, but they were not able to learn Braille. With intensified kind of intervention, they were not able even to know the letters. So there was some, only case studies, honestly, but I thought maybe you went into the depth of it and maybe you come across more how to evaluate and what to do in these cases.
Yeah,
really, because they were not able to learn Braille whatsoever, and that's the way they're learning how to read, right? I mean, they're not reading, they're totally blind, but they're having difficulty to associate the phonologic sounds with the sensory part of the Braille.
Yeah, actually there is no specific comprehensive study in this area, but as we said, there is some factors that can be integrated.
I actually have a comment, Dr. Amal. It could be because, if there is a vision impaired, we cannot call them dyslexia. So they have to have normal vision, actually. But what could be, it is the etiology of the visual impairment. What really affect the vision? It could be the tract, is not just the visual impairment in the visual center. And this might affect their ability. It is their connection with the other part which will really make them able to really learn the Braille. So if this is affected, it is, and I think this is, you could really evaluate them by doing a special MRI where they focus in looking at the tract, all the visual tract and their connection. If they indicate abnormality, then you have your answer.
Yeah, and then let me tell you the fact, we have problem how to assess the vision in kids in general. So before the school age, how to assess their vision equity. Yeah, so it need a specialized developmental ophthalmologist, which is, to my knowledge, not available here. Yeah.
Okay. Thank you. We conclude. تفضل. في question هنا. تقدر ترفع صوتك ولا لأنه عبال ما
Yeah, we go fast over the lecture to get more questions.
Yeah.
So.
تفضل.
Assalamu alaikum. Thank you, Dr. Fawaz. It's been a pleasure actually for me to be with you today and here. I have a question actually. What's our role like as a, mental health or like practitioner, healthcare practitioner, like to communicate with the people with hearing? Should we learn a sign language? Should we, like in a hospital, for example, like I know some kids can initiate and speak, and we can sometimes deliver some, information to them, like do we have approach in our health system in general, or like is there any plan in the future to communicate, to use like assisted tools? What's our role in here?
Yeah, so it's for practitioners who work with this kind of kids, they should know how to communicate with the child. So if he's having hearing impairment and he's communicating with sign language, you have to know and learn the sign language. Also for the community, so it's as we see here now, the interpreter and the news and in the media, now it's get more rights, and they should include in the community as well.
I will add a comment. Take an initiative. Start course of sign language in your hospital. It will be great. It always will help. Thank you, everybody. Excellent. And hopefully we had a very interesting and informative session. And hopefully the other session will be even greater. Shukran. Thank you.
Thank you all.
Good morning, everybody. This is me, Ayman Al-Hazmi, developmental pediatric consultant. So in the upcoming session, we're gonna have our guest from international speaker. So it's our pleasure to introduce our guest, Dr. Olaf Kraus de Camargo. Dr. Olaf Kraus de Camargo is an associate professor in Department of Pediatrics at McMaster University. He completed his medical education and pediatric training in Brazil, followed by residency in Germany, where he received training in developmental behavioral pediatrics, social pediatric, and child neurology. Dr. Kraus, he is now working as a co-director of CAN Child Center for Childhood Disability Research and member of McMaster Autism Research Team. Dr. Kraus has a lot of publication, over 150 articles on life of children and disabilities, and he is really advocate for the disability rights of the children. He's gonna give us a talk today about the intellectual disability assessment, what does number tell us, and interventions. So good morning, Dr. Kraus, and yes, you can start, please.
Thank you very much for this introduction and for inviting me to this fascinating conference. I only was able to attend the last session, and I really enjoyed the discussion about visual impairment and development. So congratulations to an excellent conference, and thank you very much to my dear colleague, Dr. Ayad Al-Wahid, who made the connection as a former fellow in our program. So she asked me to speak a little bit about intellectual disability and the numbers that we are dealing with. And often intellectual disability is on our differential diagnosis, and we rely on psychologists that do the assessments and receive often very extensive reports about the findings. And I hope with this talk to explain a little bit what these findings might mean and when to request these types of assessments. Can I have the next slide, please? So that's my disclaimer. I am not a psychologist, so I will not explain all the details of psychological assessments, and I don't have any conflicts of interest to declare. Next slide, please. So if we talk about numbers, there are some numbers that most of us are quite familiar with. So probably everyone knows their shoe size, and there might be 1 or 2 sizes off depending on the brand of shoes you're buying, but that's a common number of the natural diversity that we encounter among a population. The next slide, please. What people probably do not know is their IQ. Here's a picture of Albert Einstein that I really enjoy because my desk looks similar to his. And that's why it is often challenging to understand what these numbers mean when we receive test results, and also how to explain them to parents. Next slide, please. So when we think about intelligence, let us first look into how do we define that. And when we look back into the initial definitions, I like the first one is an official definition: the aggregate of global capacity of the individual to act purposefully, to think rationally, and to deal effectively with his or her environment. A much simpler description is simply to say it is the ability to solve problems. And that is maybe something that we can even observe in all types of interactions that we see even in a child that we are not assessing for a psychometric assessment. So we can see that in children figuring out how the world works, how a toy works, how to activate something, how to get something out of a box, how to build a tower, how to build a bridge. So these are all little tasks that we do in our assessment in a playful manner that already assess that ability to solve problems and give us an understanding of how these children are able to manage in their environment. Now, let's go to the next slide, please. When we talk about intellectual disability, we have different types of definitions in different systems of classification. Here is the DSM-5 criteria that I listed up here, which are the more recent ones. And they describe different elements to define an intellectual disability. So there are requested deficits in intellectual functioning and deficits in adaptive functioning. So we have two areas here, and I will go into more detail in a bit about that. And these limitations occur during the developmental period. So it's different from a neurocognitive disorder, for example, of a patient who had a stroke, or a patient who had an accident and then has cognitive impairments, or an elderly person who develops dementia. It is also different to the previous DSM-4, where we had clear IQ ranges that would define what level of intellectual disability is, or would give a diagnosis of different levels of intellectual disability. In the DSM-5 criteria, it is more important to assess how is the impact of the intellectual disability on the adaptive skills, on the daily life functioning of the child. The next slide, please. If we think about the mental abilities that are necessary to assess intellectual functioning, you can divide it in different areas. So there's reasoning, that means being able to understand logic, understanding an argument, why certain things happen in a certain way, or how to explain something that is going on in the environment or in the immediate contact with other people. We have the problem solving in itself that I mentioned already. Then we have aspects of planning ahead. What are the steps that I need to take to reach a certain goal? We have the abstract thinking. How do people imagine what could happen if I do something without really actually doing it? A judgment of what is safe, what is not safe, what are true facts, what are not so true facts. So judging, okay, from my experience, is that something that is possible or is something that is not possible? Then we have the whole aspect of academic learning, which is related to the academic skills like reading, writing, math, and experiential learning, the ability to learn through any experience, try and error, what very young children do and we can observe. The next slide, please. Now, if we go into the assessments, these assessments are organized in different subtests that will try to address all these areas of the mental abilities. So we have subtests that describe the verbal comprehension that can start from simple words, the vocabulary, up to instructions or more complex texts and paragraphs. We have the visual spatial element, where children are expected to understand relationships between objects in the space, or rearrange objects to form a certain picture, or recognize certain relationships in the tests. We have the problem-solving skills or fluid reasoning subtest in this area as well. Tests for working memory that can be both auditory or visual working memory. So repeating certain number of information that is presented verbally or visually, and then the child has to recall this information. And the processing speed, or you have a task that is maybe not that difficult, for example, draw certain symbols according to a number, and then do that in a sequence for a longer period of time and see how fast are you able to do this. Next slide. The other element that we have is the element of academic functioning, which is more obvious. So there are the listening skills or comprehension skills are often assessed through longer texts that children need to interpret and to describe and answer questions about those, the content about reading, writing, and math. And then the next slide, please. And then we have the adaptive element. So here's an example of one of the tools that can be used, the Vineland Adaptive Behavior Skills, which then describe from the perspective of a person that knows well the child, that could be a parent or a teacher. Often we use feedback from both areas, because sometimes the adaptive skills vary depending on the environment where the child is in the moment. And these adaptive skills are again related to communication, the receptive communication, expressive communication, and written communication, depending on the age. Then we have daily living skills like personal, domestic, community, and in the school, the school interactions, or ability to manage in the school environment. We have the socialization aspect. How do the kids get along with other kids and with adults? How do they regulate their emotions in those situations? How they're able to understand rules for play? And how do they cope when they are frustrated, when something does not go as they expected it to go? And then finally, we have the motor skills, which are more familiar to us as physicians from the motor exam, but they're gross motor skills and fine motor skills, coordination, self-help skills, and so on. Next, please. So back to the shoes. That's a slide. I don't have a source for that. I found it in the internet, just to explain how a normal distribution in many areas of biology presents itself. So there are small feet and large feet, and there is a distribution of sizes. And similar to that, if we look at the next slide, we have a normal distribution. Next slide, please. Of the cognitive skills. So this is a normal distribution description of what we understand and how we divide that normal distribution in different numbers. So I'm coming to the numbers now. And we can have different ways of describing these numbers. So that what you see here on this graphic is the use of percentiles. And below that, you see descriptive ranges, how you can describe it. You can describe an average, low average, high average, then very high, or very low, and then extremely high or extremely low ranges of functioning. And there are different types. Percentile is one way of describing this distribution, but there are other scores that we can look at. Can we have the next, please? So we have traditionally the initial score that was described as an intelligence quotient, what we still use as an IQ value. That was a term used initially when developmental assessments were done, and children were grouped according to the developmental age. So there was described an age, or assessed an age and skills of the child, and then compared to the chronological age of the child. So if you take the developmental age and transform it into a quotient, developmental age over chronological age, and multiply by 100, you have a quotient, which is rarely used anymore as a meaningful measure to describe how a child is functioning and what are the services and needs of that child. The other elements that we have are standard scores, percentile ranks, T-scores and Z-scores, and the descriptions that I mentioned. And I put in parentheses the mean value of all these scores and the lower and the higher and lower end of the of what would be still in the average range, from the low average to the high average range. So these are the typical. If you remember that normal distribution curve, this is the biggest chunk of that curve. that describes where most of the children are located. And children out of these ranges are then or extremely high or extremely low in their functioning. Next slide, please. I mentioned that just the IQ score does not really tell us a lot. What is much more important is to analyze the profiles of children in their different areas of functioning. Here's just an example from the adaptive skills. That's a screenshot from an Vineland assessment. And here we see the horizontal line is the line where the mean would be, and then you have different areas of functioning with different levels of restrictions in these areas. So we have some areas that are much lower, so these would be more difficult for this child, or the child would be functioning at a level of a much younger child. And then we have also areas that are stronger. Even if they are below the mean, they are individual strengths of a child that can be used to provide the best supports for that child. And we just heard in the previous talk from the colleague about the visual impairment is an extreme example of children that might have really significant weaknesses in anything that has to do with visual processing and using visual information, but might have strengths in other areas, like, for example, fine motor skills or tactile recognition of shapes and objects. And knowing this profile allows then the therapist and the teaching staff to design an individualized plan how to best support this child in school and in their daily activities in order to provide them the best possible participation in all these activities. The next slide, please. As these numbers might be confusing, I put in here a screenshot of a table, and you can take a picture of that QR code and download the table for you. It is an easy conversion of the different scores. For example, if you receive a report with T-scores and you want to know what does that mean in percentiles, you can use that table and then get an idea where this child is. Often percentiles are easier for us to understand as physicians because we're used to percentiles from the growth curves and height and weight, and have an idea what does that actually mean to be below the third percentile or not. But when we get a result with scores, it might be more difficult. So this is something that can be quite useful in clinical practice. Now, the next slide, please. So when do we order a psychometric assessment? Because this is then often done by, or it is done by psychologists, but most of the time we as physicians are asked about the question, is that child behind, or at what level is this child functioning? And it is important to understand that to ask for such an assessment, which is often going over many hours, sometimes 2 or 3 appointments. So it is quite difficult for families and for the children. What do we actually want with this assessment? So, and it is important to understand that it is important to have an understanding to use that assessment then to help the child further on. So we want to understand what are the strengths, what are the weaknesses. We want also to understand what level of communication is this child showing. Often we see children that seem to have quite good active vocabulary. They can explain themselves, they can argue, can describe things well, but their passive vocabulary or their comprehension is quite below that level of active speaking. And for parents especially, and also for teachers, it is important to know at what level do I need to talk to this child so that I can be sure that this child is understanding all my instructions and rules and so on. So sometimes it is eye-opening for parents when we see your child is speaking like a 4 or 5-year-old, but the understanding is more like a 2 and 3-year-old. And you need to slow down, you need to use shorter sentences, you need to use simpler words in order for your child to understand you. So they not following what you're telling them doesn't mean that they are behaving badly. They are simply not understanding what you're asking them to do. And that itself then helps also to understand challenging behaviors. Sometimes challenging behaviors are a communication problem, and knowing that level of communication is really important in order to address the child at their level. What we need to consider when we look for results of a psychometric assessment is it is always just a snapshot in time. It's a snapshot of what the child was able during that time of the assessment. It is not as objective as an MRI would be, or a lab. Well, lab value is sometimes also just a snapshot in time. But for a psychometric assessment, the motivation is extremely important. Is the child really engaged, and is the child willing to show the max? And all the tests are built in a way that they start easy and then go up into more difficulty. And depending on the motivation of the child will try harder or not to go through that sequence several times during hours to always going to their limit. So the motivation is extremely important. It's extremely important that the assessor has a good relationship with the child, is able to motivate the child to really get the best out of it. The environment is important, and the environment should be not distracting, should be an environment where the child feels safe and can really express everything that they want to express. And then the consideration of the cultural background. So all the tests have been developed, or most of the tests have been developed in Western countries and in English language. So there have been then validations for different cultures and different languages, but even in within the Western culture, there are differences. We recently developed or we validated a Dutch tool for language comprehension for non-speaking children. So it's a very specific population. And we wanted to have a tool that can, for example, assess the language comprehension of children with severe cerebral palsy that are not able to speak but seem to understand quite a bit. And even in that validation process, there were some things that we needed to adapt. So the Dutch original test had typical objects like a person cutting cheese. That was something typical Dutch, which people in Canada, North America usually do not cut cheese. They buy cheese that is in slices. So it was not a common thing to see. So we changed that task to cutting cucumbers, for example. So, and then the child had to ask, okay, for these pictures, who is cutting cucumbers, instead of asking who is cutting cheese. That was just a quick example how you need to adapt all the tests to the specific culture where they are going to be used. And if you're asking things that are not adapted to the culture of the child, sometimes you might get results that are below that level that the child actually might be functioning at. The next slide, please. Now, when we think about recommendations based on the test results, here's an overview of an article that went through clinical practice guidelines, both for autism spectrum disorder and intellectual disability, and looked at what are the current guidelines and recommendations for rehabilitation or treatment in these children. Can I have the next slide, please? And what they found here is that, and that might be very small for you to see, but you can also download the full paper on this QR code here, is the majority of interventions where there is some evidence that has been used for the guidelines are based on pharmacological interventions. So for autism and for intellectual disability, That is the biggest, and that's the big red dot that you see there that is being used. What the authors conclude in the conclusion of the article is that they were surprised that there was not a lot of evidence for any type of interventions that look into the adaptive skills of children, because these are actually the things that they most struggle with. And how can you improve these adaptive skills? And there's a big gap in research, but it's also possible that this gap is driven by the way how people think about development in a very biomedical model. And I will give another talk tomorrow about the ICF and go more into detail about this for further discussions. What might explain these gaps in research regarding recommendations? Can I have the next slide, please? And then we need to think about, if you look back into the indications for doing psychometric assessments, what are the benefits of that assessment for a child? So is this result, regardless of what result we will get, will this result help the child to participate better in the environment and will help the family to understand their child? Or is there certain harm that can be caused by assessing and using that result in a negative way for the child or the family? And these discussions need to happen before we do the assessment, before we ask for the assessment. Because once it's done, then you have a label on the child, and that label is very difficult to take away. The recommendations based on the results of the psychometric assessment should be really around identifying the strengths that can be used in daily activities and in school, and then also to be a basis to suggest accommodations for the child, both at home and at school as well. So these can be accommodations like access to technology, access to text-to-speech software. It can be accommodation having a scribe on the side if a child is able to explain verbally their knowledge but have difficulty for written output. And it is important to then assess if there is really willingness to use the results for this type of supports for the child and the family. And I put here the rights-based approach, which is a different approach. So we are not fixing children. We are hoping to help them to be parts in society based on their rights that they have as children. And for my last slide, I copied some of the articles of the United Nations Conventions of the Rights of Children. Arabic is one of the official languages of the United Nations. So can I have the next slide, please? And in Article 23, it says that every child with a disability should enjoy the best possible life in society. Governments should remove all obstacles for children with disabilities to become independent and to participate actively in the community. Article 28 says every child has the right to an education. Primary education should be free. Secondary and higher education should be available to every child. Children should be encouraged to go to school to the highest level possible. Discipline in schools should respect children's rights and never use violence. And Article 29 mentions children's education should help them fully develop their personalities, talents, and abilities. It should teach them to understand their own rights and to respect other people's rights, cultures, and differences. It should help them to live peacefully and protect the environment. Thank you very much.
Thank you so much, Dr. Krause, for this amazing presentation. And really, I like the last slide that you presented to us. Here just to reassure you that we are on the same page, caring about the same goals of the UNICEF. I'll open the floor now for any question from the audience.
Hello, Dr. Olaf. This is Ayat. Thank you for being us. Thank you for being with us today here. And I know it's too early in your time zone. And thank you for a very concise and practical presentation. So regarding the IQ assessments, I think in our area we have an overuse of the IQ assessment. I know there are some of the tests can be done as young as 2 years. And we got referral for children 2 years and 3 years asking for IQ assessment. So what do you recommend the youngest age to do an IQ, and you think that can be reflective of the child abilities, and how frequent we should or we can repeat this testing?
Yeah, thank you. Well, you are lucky that you have that abundance. We, as you probably remember, we wait here years and years to have a psychometric assessment done. But it's a very appropriate question that you're asking. Of course, you can do developmental tests like even, so commonly the Bailey scales, for example, are used at these young ages. And there are recommendations and guidelines in other countries, and we do them as well in our growth and development clinics, so where we follow up experimental children. The Bailey scales are done between the age of 2 and 3 years. But the purpose of those assessments at that age is mainly to have an understanding of the functioning of these children that have a certain risk factor. So in their case, the risk factor is the prematurity, and to allow to start with early intervention services if there are any delays detected in that assessment. So it is more to understand if a child needs further supports or not. I would not repeat that on a regular basis. So if you have an assessment, like if you have a risk factor for the development of a child, then it's probably appropriate to assess if you have the means to assess if there are delays, and if they and then be able to support this child and the family. I wouldn't repeat the test until school age, and only as well if there are still indications that there are any difficulties for the child. If the child is developing typically from the clinical perspective, I would rather await the first 2 years in school, and if there still are difficulties, then maybe repeat this assessment.
Thank you for your answer, Dr. Krause. Any other question, guys? Other questions? Okay, so I think there is no more questions, but please, Dr. Krause, I'm asking you to give a comment for one common mistakes we are facing in our daily practice regarding the overlapping between the intellectual disability and the learning disability. When to say, sometimes the people's misunderstanding, when to say this or that. So please, would you give a comment on that, please?
Yeah, that's a tricky answer to give, because there are differences even within English-speaking nations, how they define intellectual disability and what they understand by learning disability. So in the UK, it is, for example, a different understanding, or learning disability is something more similar to an intellectual disability, while in North America, there's a distinction between intellectual disability being a description of all the areas being quite low. In those profiles, for example, that I showed, you have a low scores in all areas that are significantly delayed, while a learning disability describes a child that has big dips in some of the areas, so might be very low in the verbal processing and associated issues then with language-based difficulties, for example, having a difficulty in reading and writing. So in the previous talk, there was the the example of a child not being able to learn Braille language. So that could be a learning disability in an otherwise typical developing child. And so what I usually use in explaining it to parents is really to show them also the profiles of the functioning of a child. And that allows me then to describe, okay, the child is functioning more or less at age level in these areas and is having significant difficulties at these individual areas here. And that's why we call it a learning disability. Or I can show your child is functioning behind or much lower than a typical developing child in all the areas of their development, and therefore we will call that an intellectual disability due to the low level and the difficulties in functioning in daily life.
Thank you so much, Dr. Krause, for your presentation again. And thank you for your participation. Hopefully that we will see you again in the upcoming events, and have a nice day. Thank you.
Thank you very much. Thank you very much for that invitation. I really enjoyed being with you, and I hope that one day I can be there in person as well. Thank you very much. Bye-bye.
أعتقد الآن الوقت متاح للبريك الصلاة to have your lunch، وبنستكمل بعدين بإذن الله بعد الصلاة تتمة السيشن حقنا اليوم إلى نهاية اليوم. شكرا لكم. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Welcome back after the break. Now we will have our next speaker, Dr. Abir Al-Lahabi. She is psychiatrist consultant, fellowship in developmental disabilities for all age groups. She is assistant professor at Taiba University Medical School. She's gonna give us a talk about one of the most important topics, which is the sleep disorder among the neurodevelopmental pediatric. She's gonna talk with, in the upcoming 1 hour, then we will keep the last part of the lecture for the questions. Thank you. تفضلي دكتور عبير.
بسم الله الرحمن الرحيم. Sleep is an active process. It's very important in our neuroplasticity, memory consolidation, immune function, and our mental health. In sleep, we have cycles. These cycles alternating between REM sleep and non-REM sleep. In the non-REM sleep, we will find that it has level 1 and 2 and 3, which the sleep go from deep, slow to deep, and then alternated with REM sleep. In REM sleep, as it's mentioned, it's mean rapid eye movement, and this is where the dream happened. Each cycle will be 90 minutes, and it will be repeated till the end of our sleep. These are the DSM-5 sleep disorder, and the most likely we will talk about insomnia, parasomnia, circadian rhythm sleep-wake disorder, sleep-related breathing disorder, narcolepsy, hypersomnolence, and restless leg syndrome. In assessment of sleep, we can use a questionnaire-based, either as a sleep diary or questionnaire. It's easy to apply. A parent can do it easily. It's non-invasive. And we can follow up the sleep changes for a long period. Other way of assessing sleep is EEG-based, which is the gold standard assessment. It's polysomnography. In polysomnography, we are assessing the brain waves, cardiorespiratory waves, and muscle tone. In activity-based, it's the actigraphy. It's bracelet-like. The child can wear it. It's non-invasive. It's easy to apply, but it can't detect the severe sleep disorder. These are the main neurodevelopmental disorder I will talk about: the autism spectrum disorder and sleep disorder, ADHD and sleep disorder, and intellectual disability. As we know, autism is heterogeneous symptoms with component of impairment in reciprocal social interaction, impairment in communication across multiple contexts, and restrictive, repetitive, stereotypal behavior. In sleep, it's the most studied neurodevelopmental disorder. The sleep disorder in autism will be, the prevalence will be 40 to 80. And we can find it in different studies with low prevalence or high prevalence. It's related to the diagnostic criteria and the assessment measure they are using in the study. In retrospective study, they found that kids diagnosed later with autism spectrum disorder had earlier on sleep problem. The common sleep disorder in autism, the commonest one is insomnia. Later, the parasomnia and bedtime resistance, it came second. And morning arising problem, daytime sleepiness, and sleep disorder breathing. As an etiology, sleep problem in ASD is a complex interaction between biological, psychological, and environmental and family factor. These are the etiological explanation related to autism and sleep disorder. Sleep problem arise as a direct consequence underlying the biology and genetic of ASD. Sleep problem arise as a clinical phenotype core of ASD, and sleep can be as a comorbidity. As a biological factor, there is a strong evidence that in autism there is alteration in melatonin synchronization, and also the neurotransmitters serotonin, GABA, and melatonin, which is facilitate the sleep and maintain the sleep through the night. They found it to be impaired in autism spectrum disorder. Also, the gene responsible for sleep and clock, the rhythm in our body, which is in chromosome 15, they found it to be impaired related to the GABA and sleep disorder. This theory explained a lot of the relationship between the autism and sleep disorder and the behavioral dysregulation. In autism, the symptoms like social interaction, communication, restrictive repetitive behavior, when they added to environmental factor, it can lead to behavioral dysregulation. And when we have behavioral dysregulation, we could have sleep dysregulation. Once the sleep dysregulation appears on the surface, it can aggravate the behavioral dysregulation. So the relation between the behavior and sleep is bidirectional. Once we control one of them, we can control the other one. Any comorbidity, whether medical or psychiatric illnesses, can lead to sleep disorder in autism. For example, epilepsy. And for psychiatric illness, we are talking about anxiety, depression. Anxiety itself, they found it to have higher symptom severity, more impairment in communication and social interaction, sensory sensitivity increased, and GI problem also. A lot of study talked about the risk marker for sleep disturbances. So they were talking about the age. They found that the main age where the sleep appear in kids with autism, it's between 6 to 9, and relative to 2 to 5 and 10 to 17. In other study, they found that the sleep problem never disappear, it's always there, but the type of sleep disorder, it keeps changing, and that is difficult to be tracked. Also, the IQ, the more the kids have lower IQ, the more he would be prone to have sleep disorder, especially when the IQ would be lower in language level. However, there is other study deny that effect. Also, the severity of the maladaptive coping strategy, whether an anxiety, depression, over-controlling, aggression, hyperactivity, it also led to sleep disturbances. So the effect of sleep disorder on children, it will increase the core symptoms of autism, so social interaction, the repetitive behavior, the sensitivity could always all increase. Social difficulties will be increased. Also, they found that increased awakening during the night had an effect on our appetite and growth. Medical issues such as upper respiratory tract infection and vision problem also impact on their ability to regulate their emotion, and as an ultimate result, we will have more challenging behavior. It's also affected the parent and the family. It will increase more stress to the family, impact their quality of life. It always also impair the daytime function. It affects the parent's sleep, and the sibling also will have more sleep disorder compared to other. Whenever we have a child or adolescent or adult with autism, we should assess for sleep and all the factors related to the quality of sleep. If we can use any subjective and objective measures, that would be better. If we couldn't, we should do the comprehensive history. So we should ask about any predisposing factor as a developmental vulnerability, any precipitated factor like medical condition, poor sleep hygiene, any perpetuating factor, napping or co-sleeping with parent. If the parent can keep a diary, it could guide us to where is the problem. If there is any underlying medical problem or psychiatric illness, we should evaluate the bedtime routine, any environmental variable. So the smallest things in the environment could affect children's sleep, like clothes, the bed, the noises, the light in the room. It all could affect the sleep. Screening for intrinsic sleep disorder, such as sleep apnea, restless leg syndrome, or periodic limb movement. Also assessment for food or environmental allergy. For management, we can use non-pharmacological first. If it's failed, we can go to pharmacological. The Sleep Committee of Autism Treatment Network created toolkits. In toolkit, we have 3 modules. The first one, visual scheduling of positive evening event, including the bedtime routine, the consistency, any positive behavior happened during the day. Supplementary calming module, as simple as hot shower or breathing exercise, muscle relaxation, massage. Anything can lower the arousal level in these kids. And faded bedtime protocol. For bedtime routine, for developmental kids, the gradual extinction, positive routine, bedtime faded, it's proven to be effective for kids under than 5 years old. But for older kids, we should apply the CBT, cognitive behavioral therapy. When we determine to make a bedtime routine, we should make a visual bedtime schedule. The time should be big, as a reasonable time for the family. We should provide a reminder for the family, and that should be consistent for the whole family. There is other trial for the weighted blanket. It reduces anxiety and insomnia. However, in the long-term efficacy, it failed to show any result. Also, sound to sleep mattress. It's a mattress that produces sound and vibration. So it calmed the kids by producing the sound that he is familiar with. It's proven to decrease the bedtime resistance, shorten the sleep latency. These are the medication that we can use. So the only one who's proven by FDA is melatonin, as there is a strong connection between autism, sleep disorder, and melatonin. Melatonin, we can find it as an over-counter medication. The recommended dose between 1 to 3, depend on the age and weight. There is rarely side effect connected to melatonin, but if it happened, it would be like nausea, headache, and dizziness. In melatonin, we can use it in different shape. You can use it as a gummy, tablets, sometimes crushing it. So family can use it in different way, and they can be creative when they are using it. Melatonin helps to reduce the time to sleep, but it will not help for the awakening during the night. Other medication recommended, the alpha adrenergic agonist, the clonidine. There is strong evidence for it to help kids, especially that it will reduce bedtime resistance, would reduce nighttime awakening. But we could suffer from the daytime fatigue or dizziness. For antipsychotic, there is a strong recommendation not to use it as a first line, and we should keep it for kids with behavioral challenges. If we have kids with depression and anxiety, we can go for medications such as trazodone and mirtazapine, which could have sleep efficacy and can treat depression. Iron supplement can use if the kids have restless leg syndrome, antihistamine, benzodiazepine. If it's used, we have to be careful as it could have paradoxical and excitatory response. For ADHD, sleep disorder is connected very strongly with it. If we looked for the prevalence, we will find it between 25 to 50%. For ADHD and sleep, the relationship it's a little bit complicated because either the ADHD itself produces sleep problem. So when we treat ADHD, the sleep problem could get better. And this is explained when we give stimulant medication for kids with ADHD, their sleep problem will be elevated, like they will have no sleep problems. The other way that ADHD itself the sleep problem itself can produce ADHD-like symptoms. So kids, when they have no much sleep, they will be fatigued, decreased concentration, more impulsive, and tired all the time. Or they both affected each other. The ADHD and sleep problem could happen as a comorbidity with each other. In affected individual with sleep and ADHD, we will find excessive daytime fatigue interfere with their mood, attention, and behavior, and as a result, they will be unable to function as if in school and work. These are the most common sleep disorders studied with ADHD: sleep disorder breathing, restless leg syndrome, insomnia, narcolepsy, and circadian rhythm sleep disorder. Still, insomnia is the highest among all of it. For sleep disorder breathing, any history of snoring or a possible obstructive sleep apnea during childhood is associated with 2 times of ADHD symptoms or diagnosis. Also, the incidence of sleep disorder breathing is found among individuals with ADHD is elevated. The mechanism for this, the relationship between sleep disorder breathing and ADHD is either due to the recurrent hypoxia, stress and inflammation in the brain, which could affect the prefrontal cortex. For restless leg syndrome, in restless leg syndrome, patients usually have insomnia because they have to move their leg, and they need to move their leg, make them more unable to continue in their sleep. The underlying cause of restless leg syndrome is the dopaminergic abnormality and iron deficiency. Both of them is underlying for restless leg syndrome and ADHD. There is evidence suggested that 44% of individuals with ADHD have restless leg syndrome or similar symptoms, and 26% of individuals who have restless leg syndrome have ADHD-like symptoms. For circadian rhythm sleep disorder, the most likely disorder is delay onset, where the individual go to sleep and wake up from sleep 2 hours more than what should be. For circadian rhythm, the underlying etiology is change in the melatonin, the gene connected to the ADHD and the sleep disorder. For insomnia, either it's initial insomnia or middle insomnia. It could all be happened in ADHD. For children, it's 73%. In adult, it would be 66%. The main reason underlying insomnia and ADHD is unhealthy sleep practice and lack of routine. Kids with ADHD usually impulsive. They are unable to settle down, so they would have insomnia. The relationship between narcolepsy and ADHD is also not yet clear, but they found out adults with narcolepsy would be having 2 times more likely to be diagnosed with ADHD when they are at younger age. And also evidence suggested that with ADHD experience hyperarousal and their hyperactivity impulsive symptoms could be as a compensatory behavior for the fatigue it happened to them. The link between ADHD and narcolepsy is poorly understood, but it's hypothesized that the excessive daytime sleeping in individuals with narcolepsy could result in inattention, poor executive function, and impulse control problem, which mimic the ADHD symptoms. Also, ADHD could be confused when we diagnose it with narcolepsy. For ADHD, using a stimulant could affect also sleep, either by difficulty in falling asleep, longer latency to sleep onset, and overall shorter duration of sleep. It's more common when we start stimulant therapy, taking higher dose of stimulants, or if they are younger, small, or stimulant naive. Children will be more vulnerable to adverse effect if they already have pre-existing sleep disorder or they have a comorbidity as depression or anxiety. Usually, the effect of ADHD medication on sleep would be improved with time, and it's higher on kids than in adults. So the first step in management ADHD with sleep disorder is education about the sleep disorder, the treatment, and the sleep hygiene for the parent, for the child, and if he's adult, for the spouse. If we are deciding to choose medication, we should target improving associated problems, such as daytime impairment. So if we have a child with obstructive sleep apnea, there is a recommendation to remove the adenoid or the tonsil. If he is an adult with obstructive sleep apnea, positive airway pressure devices. If we have an adult with ADHD and restless leg syndrome, behavioral intervention as modifying sleep environment. We can choose treatment with iron supplement. It would be effective. ADHD with sleep onset disorder, either using light therapy or timed melatonin. In timed melatonin, we are using melatonin 3 hours before the bedtime with smaller dose. For children with ADHD and insomnia, usually we scheduled awakening. It means we are awakening the child at specific time every day. Unmodified extinction mean the parent goes outside the room. Faded bedtime, either delaying the bedtime 15 minutes or make it earlier. For adolescents with ADHD and insomnia, CBT is recommended. Adult with insomnia, either CBT, stimulant control therapy, relaxation training, and sleep restriction. For narcolepsy, we will treat the narcolepsy. If we have sleep disorder due to ADHD medication, we usually recommend to monitor, as this effect would last for 1 and 2 months, then it will be resolved by itself. If we can stop the medication, we would stop it. It's important to implement sleep hygiene and behavioral measures. Review if there is any other sleep problem or primary sleep problem and treat it. Sometimes we need to add small short-acting stimuli in the evening if there is a rebound effect from the stimulant. If we can reduce the stimulant dose or switch it to alternative, and we can consider adding melatonin. A hypnotic agent can be tried, but we have to be careful from the paradoxical effect. Clonidine also can be used. There is open trial show that it's effective in reducing this sleep onset delay with less side effect. For intellectual disability and sleep disorder, it's the highest among the three, but there is no enough research in this area, and most of the research modifying the normal population with sleep disorder. The causes of sleep disorder in intellectual disability, kids or adult, either it's because there is a genetic problem or circadian, like they will not be exposed to light, people, so it will affect their circadian rhythm. Any physical problems such as pain, epilepsy, or medication side effect like psychotropic medication, any mental health problem, depression and anxiety, ID-associated condition like autism, ADHD, or if there is environmental factor like lightning, light, frequent checking, he's the only one sleeping while the family is not sleeping. So these are a collection of the possible cause. In adult or kids with intellectual disability, we usually look what is the causes and we try to treat it as a multidisciplinary team. So if we have someone with intellectual disability and sleep disorder, we would do the assessment. If we find any contributing factor, whether mental, physical health, or environmental, we will address it. If we find there is a sleep disorder, for example, breathing disorder, like obstructive sleep apnea, we will refer them to GP or sleep respiratory clinic. If there is other disorder like circadian rhythm, we will consider treatment with melatonin or iron. If we can use CBT as a modified CBT with them, we would use it with them. Thank you.
Thank you so much, Dr. Abir, for this nice presentation about sleep disorder. Now we'll open the floor for any question, please. Questions? فدائما, as I said before of this talk, we are double checking always with the multidisciplinary team that sleep quality as important as any intervention, لأن majority of the learning process والconsolidation والneuroplasticity والاستفادة من معظم الأشياء اللي during الانترفنشن تعلمها لن تصبح effective على long term without good sleep quality. فدكتور عبير would you just comment on this part, how important for us as people dealing with the children and doing a lot of intervention, كل في مجاله special aid كيف ممكن إحنا نساعد ونحسن to improve the quality of life through and the outcome of the behavioral intervention among neurodevelopmental issues.
Okay, so sleep itself is a core feature, whether for mental illness, for quality of life, as you mentioned, for education and function. There is a lot of recommendation, and this is what we should do in our practice. We would do the assessment, either subjective or objective assessment of sleep and the quality of sleep. And sometimes fixing sleep can help us with other modality of treatment. Like we can treat the sleep and we will find that their communication, the repetitive movement, the restless leg syndrome, all will be improved.
Thank you so much for your participation in this event. We'll see you in the upcoming events, inshallah, Dr. Abir. Thank you.
السلام عليكم. كان في سؤال دكتور عبير الله يعطيها العافية.
لا تفضل.
أولا I'd like to thank Dr. for her excellent presentation. I had just one question regarding the use of in the table which mentions the pharmacological interventions for insomnia. And in the table that mentions the pharmacological interventions for insomnia, you mentioned the use of oral iron as a sleeping aid or
as a supplement.
yes, exactly. So outside the context of restless leg syndrome, whether in pediatrics or adults, can we use oral iron to treat insomnia? Thank you.
So the evidence suggested using iron supplement when there is a restless leg syndrome or periodic limb movement. But there is a study said that using iron as a supplement can improve sleep and cognitive function. But it's not proven with others. There is a contradictory in this. But the strong is to use it with restless leg syndrome.
Okay, thank you. One more thing regarding the sound to sleep that you have mentioned, the mattress. Is it available around us?
Actually, I didn't find it. I found it only the weighted blanket, but the sound to mattress, no, I couldn't find it.
Okay, thank you. All right, I think we're done from the sleep disorder related things. We'll have break for 5 minutes, then we will continue our as per our schedule. Thank you.
Assalamu alaikum wa rahmatullah. Welcome again. In the upcoming lecture, we will introduce our speaker, Mr. Mus'ab Zahrani, Board Certified Behavioral Analyst, BCBA, Director of Rushd Platform. He's Behavioral Analyst at Preferred Family Healthcare, United States, Research and Publication Committee member at Qualified Applied Behavioral Analysis Credential Board. He is the Deputy Director of the Center for Developmental and Behavioral Disorder. Mr. Mus'ab will talk with us about an introduction on the ABA concepts and early intervention program. Welcome, Mr. Mus'ab.
Good afternoon, everyone. You hear me now?
Yes, you can proceed, Mr. Mus'ab.
It's a pleasure to be here, even virtually. We'll talk about the story of applied behavior analysis. Of all treatments available for individuals with ASD, you hear my voice now? You hear me now? Yes, you can proceed. Okay. It's a pleasure to be here. Of all treatments available for ASD individuals, ABA has scientific evidence to back up its efficacy and has seen a lot of growth in the past decades. Actually, there has been many peer-reviewed studies over the years that prove the effectiveness of ABA. It's been around for decades and had a great success in the autism community. Next, please.
Yes, Mr. Mus'ab, we can hear you. Just go with the stream.
Out of the 28 evidence-based practices, 22 of these are based on ABA. Next. Next again. 3 times. Yes. Let's go to the metrics. One more. Next slide. Next slide. This matrix displays the outcomes identified for each APP, also sorted by age group within the APP. The filled cells indicate that at least one study generated the indicated outcome for a specific intervention. Most of the APPs have at least some evidence of impact across a wide range of ages. In general, APPs tend to address a wide variety of outcome categories, ranging from 4 to 11 outcomes. Notably, 23 APPs have been shown to impact 7 or more outcome categories, and 16 APPs have been shown to impact 9 or more. Finally, most outcome categories are positively impacted by a range of APPs. 3 APPs have proven to impact self-determination, 7 impact mental health, and 9 impact vocational skills. Cognitive skills and joint attention and motor skills are linked to 13 and 16 APPs. All others categories, which are academic, behavior, communication, play, school, readiness, and social, have been successfully improved using 23 or more of the 28 APPs. The implementers were primarily research staff serving as behavior analysts, and interventionists in 52% of the studies, and coaches in 10% of the studies. Educators and related services were each identified as implementer in 20% of the studies. And parents were noted as implementers in 10% of the studies. Related to setting, nearly 50% of studies noted educational setting, 20% university clinic, research labs, 18% home settings, and finally 13% community clinic settings. Almost 80% of the studies were conducted in individual sessions, and 14 were conducted in small group settings with 3 to 6 total participations. All other group sized occurred in less than 6% of the studies. Next slide, please. Now let's dive into the core of ABA. ABA is different because it makes a difference. It focuses on the individual's needs and promote positive change. Next. ABA interventions focus on socially significant and appropriate behavior. Next. It also focuses on measurable and observable behaviors. Data is used to determine effectiveness of the treatment. Procedures are described in technological terms. Interventions are research-based and backed by the principle of ABA. And finally, generality is the end goal of ABA treatment. Next. As behavior analysts, we treat behavior based on the function, or we can call it the reason of the behavior. Either it's attention-seeking, escape from unwanted stimulus, access to tangible, or sensory. Knowing the function is the way to treatment. And the first step to figure out the function of the behavior is to look at the ABC. Next. ABC is antecedent, behavior, and the consequences. The antecedent is what triggers the behavior. The behavior is the action, and the consequences are what will increase, maintain, or decrease the behavior, or the likelihood of the behavior occurring in the future. Next. Let's see some examples here. For example, if an employee always comes late to work, the antecedent is the time, the clock that he sees, the clock that he sees before he gets to work, and the behavior is being late at work. The consequences is a reprimand from the employer. Most likely this behavior will decrease in the future if the reprimand is actually defined as a punishment, which is not the case all the time. Next. Now let's have a look at the two main types of behaviors. We have respondent behavior, in which a response is elicited by antecedent stimuli in the environment alone without consequences. This what makes the respondent behavior unique, because it is not related to what occurs after the behavior. It's related to what occurred before the behavior. And that's what we call conditioning, classical conditioning. The other type is the operant behavior, which includes most of human behaviors, including attending this conference, for example, to gain knowledge from experts in the field. So knowing that the consequence of this conference is most likely will be reinforcing, the attendance will likely to increase tomorrow and in the future. And now let's take some examples for the behavior. Can we go next? I highlighted the actual behavior and the non-behavior. So I added behaviors and examples and non-examples of behaviors. And to easily know if what you see is a behavior or not a behavior, ask yourself if it's a verb or not a verb. For example, smiling, crying, driving, these are all something that you actually do. But happy or receiving, for example, is not something you actually do, so it's not considered a behavior. Next. The types of contingencies in applied behavior analysis are three main types. We have reinforcement, which in all types that will increase the likelihood of the behavior in the future. We have extinction, which will withdraw the maintaining reinforcer to decrease the behavior in the future. And we have also punishment, which will help to decrease the likelihood of the behavior in the future. Next. Now let's move to a new related topic in ASD treatment. Research shows that early interventions for ASD are likely to have major long-term positive effects on symptoms and later skills. A study was conducted by Jessica Mayo with her colleagues in 2013, looked at 119 children with ASD between the age of 16 and 30 months. They compared the timing of children's first word with their ability 2 years later. They considered a first word to be any word other than mama and baba. These researchers found that children who spoke their first word earlier tended to have better abilities later in the childhood. And in particular, children who acquired their first word by 24 months tended to have stronger language and cognitive skills later on the children who did not meet this milestone. However, even after 24 months, the earlier children acquired first word, the better their progress was. Another study was conducted by Andrew Pickles and his colleagues on at 2020 on 192 children with ASD from the time they were 2 years old until they were 19 years old. They looked at the patterns in children's language development and noticed several interesting things. Let me share what they found out with you. All of the children improved between age 2 and 19, but their rate of improvement was quite varied between age 6. Some children started out with slow progress, but made very good progress, and other group of children had more stable progress over time. After the age of 6, the children's progress was not varied. Children continued to make improvements after age 6, but they maintained their developmental path. What this means is that before age 6, children with ASD make the most changes in the language development. And if we want to have the biggest impact on children's language development path, we need to start doing this before the age of 6, as this study suggested. To conclude, early intervention shows that the earlier is the better. And as clinicians, we see some symptoms that might disappear completely due to the fact that the client has been seen by BCBA, SLPs, OTs, and different service providers in their early stages. We see this as clinicians, and we see this as researchers. Next. It's really important to mention that as much as ABA is positively changing individuals with ASD, there's some training methods that early intervention is based upon, some of which is the discrete trial training, which is well known in the ABA field. The discrete trial training is the most systematic way of teaching and the most restricted. In contrast, the NET, the naturalistic teaching, is where the client is guiding and leading the session, and the clinician or the therapist still have the opportunity to use natural opportunities to teach different skills, but in the time that the client chooses. Free operant teaching is where the client is freely open to when to start learning and what to learn first. And behavioral response training is one of the unique ways, in teaching new skills, where the therapist will reinforce target behavior by the teaching item. For example, if I am teaching a child how to name or label banana, for example, the reinforcement is going to be a bite from this banana. That's what will make the PRT different than the other type of training in the ABA that early intervention uses. Next. Even though ABA is well known in the developmental delays and the ASD field, but we have seen more effects on ABA upon other settings and other fields. So next. For example, ABA has been proven to be effective with different areas. For example, the animal training, education, general health and wellness, gerontology, mental health, organizational behavior management, and sport. Next. To conclude, ABA is every way, is actually is around us in everyday situation. If we think about it, we are actually using ABA without even knowing that we are using it. Therefore, as behavior analysts, we tend to analyze situations in front of us, sometimes even if we are not asked to, but this will make situations in front of us easily to be understood, and will make situations that we need to improve also easy to be work on. ABA is used in schools, in communities, in home, and in workplaces. As I mentioned, we all use ABA in different ways. We all understand the consequences of our behaviors, and that's what all ABA is about. Thank you for listening, and I would leave some time for questions.
Thank you, Mr. Mus'ab, for this thank you, Mr. Mus'ab, for this professional, nice talk about ABA. Really, it gives us a lot about the main concept behind this kind of intervention. Now the time for question, as you said. Any question? I think Mr. Usama Mus'ab, it was very clear and to the point, and all the messages has been delivered for the audience. Thank you for your time, and enjoy the remaining of your day. Thank you.
Thank you so much.
I think Mr. Mus'ab, it was very clear and to the point, and all the messages has been delivered for the audience. Thank you for your time.
Thank you.
Enjoy the remaining of your day.
Thanks. Bye.
Five-minute breaks. Break for 5 minutes if needed. We are waiting for the upcoming international guest. He'll be ready within 5 minutes. Thank you.
Welcome again. It's my pleasure to introduce and welcoming our next speaker from overseas. Dr. Ronald Garth Smith is a developmental pediatrician and medical director of Kids Inclusive Center for Child and Youth Development, associated professor in pediatrics at Queen's University, Kingston, Ontario, Canada. Dr. Smith has more than 15 publications in peer-reviewed journals, has been awarded 3 teaching awards at Queen's University, has worked with child and youth with a range of developmental disabilities, including autism, for more than 26 years. So welcome, Dr. Smith, and please, you can start your talk. Thank you.
Very much for inviting me to participate in this wonderful conference. It's a very important topic, and I hope I can do it justice. First slide. So the topic I'm going to be speaking about today is psychiatric comorbidities with autism spectrum disorder, and I'll give a bit of an update on the challenges of diagnosis and treatment. Next slide. I have no disclosures or conflicts. Next slide. So the objectives of this talk is that by the end of this presentation, participants should better understand the range of psychiatric comorbidities that may coexist with autism spectrum disorders, and I'll give a few examples. Obviously, in the time I have, I can't go through all the comorbidities, but I'll go through as some of the more important ones. I'll also discuss the impact of comorbidities on the child, youth, or adult with autism, and the potential challenges of diagnosing these comorbidities and the potential challenges of treating them. Next slide. So this slide basically shows the combination of the typical features of autism, which I'm sure you're very aware of by this stage, and some of the conditions that coexist with that can affect the presentation of comorbidities. Things like the timing of diagnosis of autism, the severity of the presentation, the presence or absence of language skills, and so on. Next slide. So in this slide, what I'm trying to show is that if I can just enlarge the screen here, just give me 1 second. Yeah, I'm just having a little difficulty seeing my slides. Anyway, so this slide is just showing that the different symptoms or signs of autism can be quite variable, and that's one of the reasons why it's called a spectrum. So, for example, some of the kids that will have more social difficulties than other kids. Some will have more sensitivities than other kids, and some kids will have more language than other kids. So depending on the degree of severity of each of those presentations, whether it's language, social skills, etc., the child will look different. Next slide, please. So when it comes to comorbidities, we often divide comorbidities into psychiatric or developmental, and also into physical or medical. The psychiatric comorbidities are quite large, and as you can see from this slide, they include things like anxiety, like attention deficit hyperactivity disorder, depression, intellectual disability, eating disorders, developmental coordination disorder, etc. All of these, this is not exhaustive by any means. There are several more that I could have added to this slide, but I just wanted to give you an idea of just how extensive some of these comorbidities can be. Next slide, please. This one is the more medical comorbidities, which include conditions like sleep disorders, immunological disorders, gastrointestinal problems, epilepsy. Epilepsy, by the way, is extremely common in kids with autism, ranging between 14 and 40%, and can certainly have an impact on some of the psychiatric comorbidities as well. Next slide. So what are the impacts of comorbidities on autism itself? First of all, it may delay the diagnosis by covering up or camouflaging the primary symptoms. It may complicate the treatment of autism, and it can definitely negatively impact the prognosis. If a child, the more comorbidities a child has with the autism, the worse the prognosis generally is. The later the diagnosis of comorbidities, also the worse the prognosis can be. It can impact the child at times more than the autism itself. So sometimes we'll see, for example, children with autism and anxiety, when the anxiety surfaces or appears later in life, like in the late childhood, the symptoms of the anxiety can actually appear worse than the autism symptoms themselves. Some comorbidities can actually mimic autism features. For example, obsessive compulsive disorder, anxiety disorders, and ADHD share symptoms with autism. And that is one of the reasons why autism can sometimes be delayed in diagnosis, because the first set of symptoms that appear would be the symptoms of the other comorbidity, like attention deficit hyperactivity disorder. Next slide. So why is it, how is it that psychiatric comorbidities can impact the diagnosis? Well, I've shown here three colors: red, blue, and yellow. And when you mix those colors together, they all appear different. So for example, red and yellow can present as orange. Blue and yellow can present as green. Similarly, if you have autism and another comorbidity, the appearance of the symptoms changes by the presence of this comorbidity. So the more comorbidities you add to the child with autism, the more difficult it can be sometimes to make the diagnosis, because these comorbidities are impacting the appearance of the primary symptoms of autism. Next slide. So how can comorbidities further complicate the treatment of autism? They can increase emotional dysregulation. Emotional dysregulation is something that's commonly seen in kids with autism. However, if you add a comorbidity to that, like anxiety or ADHD or mood disorders or sleep disorders, that further makes the child more irritable and more emotionally dysregulated. It will generally lead to more severe impairment as a result of the cumulative effects of having more than one diagnosis or disorder. It can interfere with responsiveness to ABA treatments. You just heard an excellent talk on ABA treatment, and the presence of these comorbidities can impact the success of the ABA treatment to some degree. Treatment of the comorbidity may further negatively affect some of the symptoms of autism. For example, treatment of ADHD with stimulants can affect appetite and sleep, two conditions that commonly coexist with autism. An SSRI, which is used to treat anxiety, for example, can affect sleep, which is already something that, that children with autism struggle with. So by activating the child, it may impact sleep as well. SSRIs are also shown to affect certain aspects of sleep, like the presence of REM sleep, REM sleep, which is the dream part of sleep. Next slide. So how can comorbidity identification improve autism management? When you diagnose a problematic symptom and it's recognized as manifesting another comorbidity, for example, anxiety or ADHD, you can then treat that comorbidity, which can help in the overall treatment of the autism by improving the success of ABA treatment. So treating a child with ADHD allows the child to be more responsive to the ABA treatment, because otherwise they'd be so distracted by their ADHD that they're unable to attend to the whole process of ABA therapy. It may reduce emotional dysregulation. As I mentioned earlier, the more comorbidities present, the more emotionally dysregulated the child is. In some cases, treatment of the comorbid condition better enables recognition of the autism by removing that from the child. So for example, using the example I had earlier of the two colors, if you have yellow and blue, instead of having green, which makes it difficult to see blue or yellow, if you remove the blue, the yellow is more clear. And therefore, if you treat the ADHD, maybe the autism will appear more readily. Next slide. So let's look now at some comorbidities in more detail. Next slide. Attention deficit hyperactivity disorder is probably one of the more common comorbidities that's seen in children with autism. Previously in the DSM-4, we were not allowed to make the diagnosis, although many of us did regardless, because we saw the symptoms and we figured treating it would probably help the treatment, the overall treatment of the child. 15 to 25% of children with ADHD will also have autism, and 50 to 70% or even more children with autism will have ADHD as a coexisting problem. Other diagnoses, often the diagnosis of autism is delayed by the presence of ADHD. In fact, there was a very good study published in one of the pediatric journals recently, which showed that many children who were diagnosed with ADHD between the ages of 3 and 6, 3 years later were diagnosed with autism. And what they felt was that the presence of the ADHD actually delayed the diagnosis of autism, which meant in delayed treatment of the autism itself, which impacted prognosis. The other thing that's important to recognize here is that the children, what they were also suggesting from this study was that any child that's diagnosed with ADHD before the age of 6, the person making the ADHD diagnosis should look very carefully for symptoms of autism spectrum disorder. In the general population, the prevalence of ADHD is about 5%, whereas in the autism population, it's significantly higher. The children with ADHD share symptoms with children with autism. For example, children with ADHD have social difficulties. They tend to get too close to their peers. They tend to be very difficult to engage with, to interact with. So you can see their shared symptoms. Many kids with ADHD always want to be first. They always want to win. And that is a shared symptom with many children with autism as well. So the other thing I just wanted to mention is that together, these ADHD and autism create a more severely impaired social and adaptive skill combination with children with autism. Next slide. So what about the diagnosis of autism? As I said, the diagnosis of ADHD in youth with ASD can be impacted by shared symptoms. For example, they both have social impairment. They both can have cognitive impairment or learning difficulties. They also both share inattention. and they can have executive dysfunction, things like organization, memory, and so on. They share comorbidities. Many of the kids with autism and ADHD have comorbidities like developmental coordination disorder, tics and Tourette's syndrome, and others, including anxiety. Next slide. So the diagnosis of ADHD in youth with ASD can be impacted by the shared symptoms. Sorry, I needed the next slide, please. Yeah, so what about diagnosis then? It necessitates, the diagnosis of ADHD in a child with autism necessitates a detailed neurodevelopmental history. And one of the things that we're recognizing now is that many people are too quick to make the diagnosis of ADHD just based on symptoms without looking to see if all of the symptoms together actually make a diagnosis of ADHD, or could it just be isolated symptoms that appear at different times rather than together to make the diagnosis of autism, sorry, of ADHD. The other thing to remember is that there are lots of lookalikes for ADHD. Kids that are anxious can look like they have ADHD. Kids that have intellectual disability, because they're often delayed in their development, can look like they have ADHD. So we have to be careful to look at all those different things and make sure they're not mimicking the symptoms of ADHD and actually representing something else. The other thing I just wanted to mention is that it's really important to recognize that treatment of the ADHD can impact other things. So we will get into that in a few minutes in more detail. Next slide, please. So what about treatment? So stimulants are still the first line treatment for ADHD. So things like methylphenidate and various amphetamines, those are the primary treatments. However, both of these treatments it's really important to start them lower and slower than in children without ASD or intellectual disability, because they're much more sensitive to the side effects of these medications. So when I see a child with ADHD and autism, we always start at a much lower dose than we would start with a child without ASD, because of the risk of the side effects being more significant. It's also important to recognize that only about 50 to 60% of kids with ASD and ADHD respond to treatment with stimulants. You can also use non-stimulants like atomoxetine, which has been studied in a few open label studies, and guanfacine XR, which is a new treatment in the last few years, has been studied, but it mainly tends to improve hyperactivity and impulsiveness rather than the inattention as much. Neuroleptics like risperidone and aripiprazole have also been used to treat ADHD, where the other two sets of treatments, including stimulants and non-stimulants, are unsuccessful, and especially if there's coexistent emotional dysregulation or tics or Tourette syndrome. Next slide. So the stimulants, as I said, can affect the child by causing appetite suppression, insomnia, can increase anxiety, and can cause mood alterations. And because of this, we always start low and go slowly. Atomoxetine, which is often used, can cause headaches, nausea, and dizziness, which can further impact compliance in taking these medications. So again, start low and go much slower than you would in a child without autism. Next slide. Anxiety and autism. So it often coexists with ADHD and can mimic ADHD, as I mentioned before. So consider if you see a child that may have anxiety with autism and you suspect ADHD as well, it's better to treat the anxiety first and see what transpires before treating the ADHD. the symptoms of anxiety can worsen or exacerbate sensory issues and can also worsen emotional reactivity. It is often, anxiety can be worsened also by changes in routine, by losing access to preferred activities, certain environments which overstimulate the child, like, for example, a grocery store or a gym or babies crying, etc., will increase the child's sensitivities and increase their anxiety. Separation from a parent or familiar figure can also worsen anxiety. Next slide, please. So this is a slide which I'm not sure if you can see it very well, but it was a study recently published where they showed a strong association between anxiety and sensory issues. So autistic kids have a number of sensory issues, including sensitivity to noises, sensitivity to touch, etc. And the presence of anxiety can significantly worsen sensitivities in children with autism. So it's a kind of a loop where the more sensory issues there are, the more anxious a child gets, and the more anxious a child gets, the more sensitive they become. Next slide. Next slide. Yeah, symptoms of anxiety, symptoms of anxiety in autism include pacing, running away, being restless, looking scared, having more self-injurious behaviors, aggression, meltdowns, picking at their body, picking at scabs on their skin, more repetitive behaviors and questions, and poor sleep and frequent awakening. The reason I put this list down is because kids with autism have a hard time expressing emotions. So if you ask the child with autism, are you anxious? They will often tell you no, or I don't know. So we have to look at symptoms to determine how likely it is that they have anxiety. Next slide. What about treatment? The treatment of anxiety, first line for the mild and moderate, should be cognitive behavioral therapy. If it's available, we have difficulty sometimes accessing this, but it's something that should be sought first if it's available. For moderate or severe anxiety, the medications are tried, although there are very few studies done on children with autism and the use of SSRIs, for example. The ones that are most used are fluoxetine, sertraline, and citalopram. The importance of treating it early is because if it's not treated, there's a higher risk of development of depression and increased maladaptive behaviors like self-injurious behaviors, etc. Next slide. Tics and Tourette's. It's often one of the strong differential diagnoses for autism. And the reason for this is tics and Tourette's syndrome frequently have coexisting diagnoses of obsessive compulsive disorder, but the type of obsessive compulsive disorder is one for symmetry. So kids with Tourette's syndrome, if they have OCD, will like things to be symmetrical. They don't like things moved out of order, which is exactly like what kids with autism like. Complex tics can mimic or look like stereotypic behaviors in autistic kids. Many kids with Tourette's syndrome have coexisting ADHD, about 50%, similar to autism. There's also a high frequency of coexisting anxiety. So it's very complex tics are very difficult to differentiate sometimes. And in fact, if you have a neurologist and a psychiatrist and a developmental pediatrician looking at a child with complex tics, and you ask them, is that a complex tic or a stereotypy? They often have difficulty giving you the right answer. Next slide. That's just a quick picture of Tourette's syndrome, and you can see the wide range of coexisting problems that can occur with it. Next slide. So treatment of tics it's really not imperative that we treat tics unless they're causing impairment in the child or in those around the child. So if the child has tics, like vocal tics, and it's disturbing other kids, or if it's disturbing the child, then they should be treated. If it is treated, sometimes we try, first of all, to treat the associated disorders first to see if that will decrease the tics. So for example, treating anxiety may decrease the presence of tics. Treatment of the ADHD can either worsen or in many cases improve the tics. Tics can also be treated with behavioral treatments, and that can be quite successful. The two types of medications used to treat tics and Tourette's are the neuroleptics. However, they have a much higher side effect profile. And alpha-2 agonists like guanfacine or clonidine are also used, but they have a much safer profile. Next slide. OCD, I'm not going to spend too much time on because I realize I'm running out of time. But the way to differentiate OCD from behaviors with autism is that people with OCD have what is called ego dystonia. In other words, they have to do that behavior. They have to do whatever it is that they're doing. They have to line up their things in symmetry. Kids with autism like to do their behaviors. They don't have to do it, they just like to do it. And that's one of the most important differentiations. Next slide. I have one outstanding question that I want to state, and that is the questionnaires that are frequently used, for example, to diagnose ADHD, anxiety, depression in kids that don't have autism may not always be accurate in kids with autism. And that is an active area of study currently. So for the time being, we are using these questionnaires like the Conners or the SNAP questionnaire for ADHD and various questionnaires for anxiety and depression. But in the future, hopefully we'll have new questionnaires that are more accurate in diagnosing these comorbidities. Next slide. These are my references. Next slide. Thank you for your kind attention and for inviting me to this conference. Questions?
Thank you, Dr. Smith, for this great talk about comorbidities from psychological point of view about our autistic children. Now the time for questions. Any question? I think Dr. Smith make everything straightforward and clear for the audience. On behalf of the scientific and organizing committee, thank you, Dr. Smith, for accepting our invitation. And we know it's still early in your area, but have a nice day. And really, we're glad to have you in our event. Hopefully, we'll see you again, inshallah.
Thank you so much for inviting me. Have a great day yourself.
Thank you. Bye-bye. يعطيكم العافية جميعا. أعتقد أنه خلصنا رحلتنا في اليوم الثاني. نراكم غدا مبكرا. نبارك لكم نجاح اليوم الثاني.